starting our second day, and we have a slight change in schedule. PG papers presentation will be postponed for some time because all the PGs have not yet arrived. Frame, sir.
Next to me. प्रणाम सर। हाँ सर, अभी आए नहीं है, दो तीन मिनट में आ जाएंगे तो हम फिर आपको बात करें। आप ऐसे आइए ना सर कॉन्फ्रेंस में। इनका वही तो फर्स्ट 10 साढ़े 10 बजे का जरूर होगा, क्योंकि फिर उनका फ्लाइट है ना। ठीक है, तो आप आ जाइए सर। नहीं फर्स्ट हाफ में हुआ, फिर उनका फ्लाइट है 1 बजे। ठीक है ना।
Good morning, everyone. I'm Dr. Amar Prem, consultant surgical oncologist at Jharkhand Cancer Center, Ranchi. Since this is the first presentation, obviously crowd is less, and this reminds of at present viral social media meme that in these medical conferences either the crowd is the next presenter or the next speaker. So let's start on my topic, early diagnosis and management of gallbladder cancers. Whenever we hear the term or whenever we get a diagnosis of gallbladder cancer in our OPDs, there is a general nihilistic view about this malignancy. Everyone thinks that the prognosis is going to be bad. But is it so that the prognosis is so bad, or can we do something about it? This is going to be the topic of my discussion. So, gallbladder cancers are rare but very fatal malignancies worldwide. But is it rare in our part of country? No. If we sit in our OPD, then a large number of single organ malignancies will be gallbladder cancer malignancies. I will be showing our Indian data of a tertiary care center also towards the end. However, geographical variability is quite high. In India is among regions with a high incidence of gallbladder cancer, particularly in northern and northeastern India. And most of these patients gets diagnosed in locally advanced or metastatic stage. But why it's so? As I told, that generally we held a very nihilistic view about this malignancy. This is a SEER database. What we can see is if we diagnose and treat the disease in localized state, that means when the disease have not spread to the regional lymph nodes, prognosis is not that bad. It's not that bad as like stomach cancer or pancreatic cancer. Problem happens when we diagnose it when either it's already spread to the lymph node or there is distant metastasis. We always talk that most of the gallbladder cancers are diagnosed in late stage, but why it is so? It is so because of its anatomical location. It's hidden behind the portion segment 4B and 5 of liver. It mimics most the presenting features between benign diseases like gallstone disease or GB sludge and GB malignancy is not very different. So very vague symptoms. Microscopically, there is absence of submucosa and very thin but highly vascular muscularis propria. And all these things leads to early metastasis either to nodes or to liver or to distant mets. This is a pictorial representation why detecting a gallbladder malignancy is difficult. If we can see, it's in GB fossa, and if the disease is on medial side, that means either in the neck of gallbladder or in cystic duct region, then the chance of infiltrating porta hepatis is quite high. Particularly in diseases of GB neck, 5 millimeter medial to it will infiltrate portal vein or CBD or to the hepatic artery. And if it's 5 millimeter lateral, then it can be treated. There is a very good paper by a Japanese population which they had presented in 2014, and what they had suggested that rather than taking all gallbladder malignancy as one entity, divide it based on anatomical location, not on based on TNM but on anatomical location. What they had suggested in that paper is, so this was the paper. What they had suggested was separate lateral, that means fundal lesions from the GB neck lesions, because GB neck lesions are going to be bad, and these fundal lesions, even if it's quite big in size, can very well be resected, and the prognosis is going to be good in this group of patients. How does this gallbladder cancers present? There will be mainly 4 kinds of presentation. Either they will be presenting as incidental gallbladder cancer. This definition is that someone have operated a gallbladder thinking it as a GB stone or GB sludge, or patient was symptomatic for it, got the GB removed. When it was sent for histopathological examination, there was malignancy in it. This is incidental gallbladder cancer. In Western population, a large number of patients gets diagnosed by this method. However, in our part, in northern Indian data, it's around 3 to 5% of patients who gets diagnosed with in this way. That means 3 to 5% of all cholecystectomies done get diagnosed as gallbladder cancer. Or if a surgeon have entered into abdomen thinking it as a gallbladder stone, but inside we find that there is malignancy. Or before taking for surgery, when the imaging was done, it was detected as mass. Or when a patient present with signs and symptoms, it's already advanced, like jaundice or in METs. These are NCCN guidelines how to manage all these 4 categories. So if there is incidental finding on pathologic review, and on HPR if it's T1A, that means only lamina propria have been involved. In that case, we can observe these patients. However, if there was a cystic duct node positive or T1B or higher, in all these cases, we need to stage the disease first and then go ahead with treatment. Stage the disease, how to do it? We need some anatomical imaging, that anatomical and objective, that doesn't include ultrasound. As per the guidelines, we have to do either CT or MRI abdomen to stage the disease, and if the disease is regional, we need to go ahead with radical cholecystectomy first and then adjuvant treatment. What are the scenarios in which we will give chemotherapy first, that I will discuss also. So what is this radical cholecystectomy and how is it different from this population in whom simple cholecystectomy was done? So in radical cholecystectomy, with respect to gallbladder fossa, there will be segment 4B and 5. So we remove around 3 centimeter wedge and we clear porta of all lymph nodes, so that after the procedure, my CBD, hepatic artery and portal vein should be bared of all fibrofatty tissues. Something like this. This is of one of our cases in which portal dissection have been done completely. This is a hepatic artery, this is a right hepatic artery, GDA, this is our CBD, and portal vein is lying behind. So we need to bear all the fibrofatty tissue of the porta. Sometimes if the lesion is like medial, as I was talking about regarding cystic duct, it will compress on CBD or it will directly infiltrate CBD. These patients will present with jaundice. This patient had already been ERCP stenting was done, and then at the time of surgical resection, we had done complete biliary tract excision and hepaticojejunostomy was done. What to do if a patient had been taken for surgery thinking it had gallstone disease, however inside we find that there may be malignancy? So at that time, we have to decide whether we have the expertise available for hepatobiliary resection or blood have been, I mean, in that case, if everything is ready, we can go ahead with radical cholecystectomy and thereafter stage the disease. However, if expertise is not available, it's always better to abandon the procedure and refer the patient to appropriate center for doing the complete radical cholecystectomy. This is important because as I was discussing that this is a bit aggressive disease, so correct first time treatment is important in this case. Suppose if we detect a mass on imaging, what to do? Most of these patients will detect this mass on ultrasonography. So in those cases, we need to stage the disease properly, which includes either CT or MRI. To know the liver function test, we need to do LFTs. CA and CA 19.9 are the tumor markers for this disease. After this, if disease is resectable, we need to do radical cholecystectomy, and if it's unresectable, then we need to get biopsy done first and then go ahead with chemotherapy. This slide shows what is the sensitivity and specificity of multiple scans in case of CAGB. What we can find out that the sensitivity and specificity for gallbladder cancers by ultrasonography is quite less. And most of the times what we find that next to ultrasonography, most of the people does MRI or MRCP. However, the sensitivity of properly done CT scan is also equally good, and as a surgeon, I feel more comfortable in reading the scans myself. So what we can find is that the sensitivity and specificity of CT also is not less than the MRI or MRCP. So in Indian population, we suffer from both underdiagnosis and overdiagnosis. This was a paper which have been published by TMH Mumbai. In what they showed was that based on imaging modalities, when we take patient taking it as malignancy, around 50% of the times it appears to be benign diseases. But they were able to detect it as they had done intraoperative frozen section in almost all of these cases. So around 51 alternate patient, almost 50% of the patient were benign. So when to give neoadjuvant chemotherapy, that means giving chemotherapy before surgery in a case of gallbladder cancer, there are 4 criteria mainly. If it's T3, T4 disease, that means liver infiltration more than 2 centimeter, or patient had presented with jaundice. In case of N1 disease, if there are nodes in hepatic artery, hepatoduodenal ligament, or retropancreatic nodes, or there is one of the vessels involvement which can be sacrificed later on. In cases of incidental CAGB, that means a patient have been operated taking interstone and we found out in HPR that there was malignancy. In these cases, if on staging workup there is residual disease, or if there is nodes disease, or there is jaundice with type 1, type 2 block, all these patients we should consider for giving chemotherapy first and then taking for surgery. As I had told that I will be showing Indian scenario later on. So this data we had collected from TMH Varanasi. This is a 18 months data. Out of 25,000 patients visiting our hospital in 18 months, around 2,200, roughly around 2,300 were gallbladder cancers. And it was 9.1% of total hospital registrations, including solid and liquid malignancies. This is quite high. In worldwide data, it's around 1% of hospital registrations. And in most of these Western population, it's around, the incidence is around 1 per 100,000 population. However, in our country, it's more than 10 per 100,000 population. It's 2294, around 725 were male and a double of it were females. Around 23, that means around 6.8% were incidental. That means operated by a surgeon and later on we found out that it's a malignancy. And a notable feature in our population was very high default rate and very high advanced stage at presentation. Around 50% of the patient had defaulted after diagnosis of gallbladder cancer due to various reasons. And of the whole, around 10% had operable disease and around 25% had locally advanced disease. So what can be done to like diagnose early or cure get cure of this fatal malignancy? Should we be doing prophylactic cholecystectomy in all patients, as we say in Hindi, na rahega baans na bajegi bansuri? So there have been different papers. One is Indian population and one is an international publication. Data is still not very sure supporting prophylactic cholecystectomy in all asymptomatic patients. However, in Indian population, during MS general surgery training, when a large number of trainees get trained with cholecystectomy first and the risk of bile duct injuries are less, this can be thought of. So the way forward is high-end research from the region to whom it matters. It matters to northern India, so the research needs to be done over this part. And high index of suspicion needs to be raised, developing infrastructure like frozen sections and good IR facility to get a USG guided FNSE or biopsy to diagnose it first, and radical curative treatment in early stages. Thank you. I'm open to questions, sir.
Doctor, if there is suspicious lesion on ultrasound or CT which is not certain it is benign or malignant, so what do you suggest them? Do a biopsy, then proceed with radical, or straight away suspicious lesion proceed with radical?
Okay. So sir's question is, suppose if there is a suspicious lesion on ultrasonography or CT, should we go directly ahead with radical cholecystectomy or should we get a biopsy or FNST first? No, sir. If there is a suspicious lesion on CT scan, if it's non-metastatic, if it's a regional disease, we should go ahead with surgery first, radical cholecystectomy with complete clearance of nodes. Now there is a term which have been commonly used, that is called a simple SOS radical cholecystectomy. So when we have taken in OT, rather than going ahead directly with radical cholecystectomy, if still I am in doubt in OT, I will do a simple cholecystectomy first. And if there is facility of intraoperative frozen section, get it done first. By the way, we are getting a frozen section in Ranchi also now. It's already there in 2-3 centers. So we are getting that intraoperative frozen section first. If there is malignancy, go ahead, get the liver wedge, clear the porta. If it's a benign disease, work is done.
Dr. Aman?
Yes, sir.
Can I just interfere here a bit? Sir asked a question about if you get a suspicious lesion on ultrasound. Fine, I think, the today's era is probably that one should, if available, one should go for an endoscopic ultrasound, take a FNB, there is a fine needle biopsy, the results are available to you in a span of 2 hours, and then you can decide whether you should go for a radical cholecystectomy or something else.
Correct, sir. But the sensitivity for GB lesions is with EUS is not that much as it's with the bile duct and our pancreatic lesions. So suppose if there is a doubtful lesion on fundus or doubtful lesion slightly on the neck, then still that suspicion will remain, sir. So what we do is, if there is suspicion lesion on ultrasound, we get a good triphagic CT. Most of the times its sensitivity is more than 80%. So mostly we will be clear. And when we had taken in OT, again that will be the second check. If we are still in doubt that whether it's benign or malignant, remove it, remove the gallbladder, send it for frozen section. If it's malignant, we are 100% sure.
Dr. Amar, I'll stop.
When do you go for radical cholecystectomy after a finding of incidental?
Yes, sir. That I should. After incidental gallbladder cancer, if it's TU1B or more, we will stage the disease by doing a good CECT abdomen. If in that case, if it's resectable, go ahead with radical cholecystectomy. There are 3 criteria when we go ahead with neoadjuvant.
The time period, time gap.
Roughly around 6 weeks, sir. Roughly around 6 weeks.
Dr. Amar, my 2 queries are regarding GB polyps, either solitary, multiple, small, large, stable over the time. Cholesterosis. These are the 2 things that patients are very apprehensive about. So what's your take on that? How to handle that?
Sir, so if we go about the literature review, the guideline says observation, but there are one is from Chile and one is from the Indian subcontinent itself. That this observation suggestion is good for the population where risk of malignancy is less. However, in Indian population, particularly North Indian, if a patient is female or multiple factors are there, in these cases, rather than taking risk, I would suggest to go ahead with simple cholecystectomy done in these cases.
So no observation for solitary small.
So small can be, sir, like, but if it's like a centimeter or so, we should definitely go ahead.
Side, female sex, 50
Yeah.
plus, family history of GB cancer. These are the high risk.
The high risk feature, yes, sir.
Thank you.
Yes, sir.
Yeah, Dr. Amarpal, nice overview of the topic. The one question is, not question, are you aware of any plan of the government or any academic institutes to have a early diagnosis of gallbladder cancer?
Sir, there are multiple like plans had been going on. One was particularly in North India and one was in like SGPGI also had started that. Particularly what they were detecting was a few of them was like doing a study of liver flukes. They had related it with a high risk population and there is a paper also of mustard oil consumption in northern Indian population. But a definite outcome have not yet come, sir.
Dr. Amar, where do you place endoscopic ultrasound in the evaluation of GB cancer?
Sir, if it's a lower CVD lesion,
CMRI and all, but
lower CVD, when there is lower CVD lesion or if the patient is presenting with jaundice, I'll get it.
I'm asking about CAGB.
If it's not with jaundice, I won't get it done, sir.
Yeah, in connection of the previous mustard oil, always it is claimed that the mustard oil is culprit, but mustard oil is highly adulterated. So it is the adulterated mustard oil or it is the original mustard oil? Because we see economic level, the mustard seeds are costing this much and it produces a oil of this much. So the price at which we purchase the mustard oil is logically claimed that it is the adulterated mustard oil. Do you have any idea about it is whether it is the adulterated mustard oil or is the pure mustard oil?
No, sir.
Nice lecture. One question. There is one study, very old study, done under guidance of late Professor Rakesh Tandon from AIMS. And they had compared different centers like SCPGI, AIMS and BHU and few more centers where they collaborated that silent gallstone with in TIFAT, the PI antigen positivity relates to gallbladder cancer. What is your take on this?
Sir, the same. I think that the paper which was published by the Indian population about prophylactic cholecystectomy was one of the extrapolation of that data only. And they had shown that what they had suggested in that paper was in Indian population, high risk population, doing a prophylactic cholecystectomy, particularly in females, won't be a bad idea, but have not been validated. Thank you.
Thank you, sir, for the excellent talk. So for our next talk, we have Dr. P.K. Agarwal, sir. Sir is a senior gastroenterologist from Dehradun, and sir has a lot of name and fame in that Dehradun. And I welcome sir for this talk, and it's a very important talk. What's new on chronic constipation?
Good morning, friends. First of all, my heartfelt thanks, to the organizing society of BJISGCON for having me here today. And of course, nowadays I think the number of conferences have gone to that level, and so many of them are being done probably on day in and day out that the gathering gets constipated. Because all of us probably, most of us, are considered to be knowing everything probably, and Google Baba has given Gyan like anything. We all know that constipation is something, as soon as a person comes to you in a clinic, we all jump on to conclusions giving treatment. And I think this happens with most of us because being busy practitioners, nobody wants to go into it, whether it's a primary one or a secondary one. Primary one is basically the chronic cause, and secondary one has to be either because of the underlying illnesses which are coming up or all because of the lifestyle modification factors. Stages we all know, I think all of us are aware about these terminologies called normal transit constipation, slow transit constipation, dysenergic, slow transit dysenergic constipation, as well as the functional constipation. So I thought, why not give you certain algorithms, especially to the residents here, if you're interested in, that if a person of slow transit constipation, which is the most common one, comes to you, what exactly you need to do? You need to see, first of all, what's happening. As I said a minute back, that all of us jump onto giving laxatives in any forms. If the person improves, fine, go ahead with it. If the person doesn't improve, then definitely we need to think about that what's happening to the person. Whether it's a male or a female, females in fact have got more constipation nowadays than males. क्योंकि उनकी बात नहीं मानी जाती घर में, इसलिए दिक्कत होती है. So repeat the colonic transits studies. If they are delayed, fine, consider, whether it's gastric emptying is proper or not. If it's normal, then you have to go for adjustment in the medication part of it. If the person is having a good consideration of the emptying of the rectum with the change in medication process, it could be a slow or a normal transit. But if it is not so, then one has to think about doing a tachography, or one has to go for doing an anal manometry and the other procedures which will come over later. So what all are the causes of common constipation? Residents you all must be knowing very much that diabetes mellitus is the most common indication. Now all our patients, whether we are ourselves or diabetics, two things happen. Either you are constipated over a long period of time, or you get intermittent diarrhea coming up. Autonomic neuropathy is one. Husband disease causes constipation, which is mostly seen in the young kids, that is the infants as well as the neonates. Then you've got central causes like Parkinson's disease in the elderly patients and patients with multiple sclerosis. IBS is a part and parcel of your chronic constipation. In the next few slides, I just try to tell you that IBS-C as well as the CIC, that is the chronic idiopathic constipation, in fact are going hand in hand. All of us know about the neurological disorders. We all know about the idiopathic constipation, as I said so. So what exactly is the pathophysiology? It has to be either a chronic obstruction, could be because of a neoplasm, a volvulus, or a stricture, or could be because of a motility disorder, as happens with patients, especially with chronic laxative abuse. Because everything is available on TV nowadays, be it suffer and that suffer, and ultimately patients suffer. So the outlet obstruction which usually happens is, could be because of interception of the anterior wall of the rectum, which usually happens because of a rectal prolapse, mild one, or even at times of chronic straining, which a person feels there is not passing stools, and in ladies because of vaginal deliveries. The pathophysiology of IBS-C also has got the same thing. It's a three-part altered thing because of the altered gastrointestinal motility, the visceral hyperalgesia, and of course the psychosomatic process which are coming. So for this there are multiple studies coming up. The EEG nowadays has come up because to know about the gastric outlet clearances and other things. And of course, thinking about two things, that if a person has got a constipation, could be either a chronic idiopathic one or a person has got an IBS-C, one should have an algorithm which tells you about the approach to a patient with chronic constipation. If a person is absolutely all right without any comorbidities, perfect, fine, no problems at all. But if a person is elderly, that is a person who is more than 45 years of age, if a person has got alarm symptoms in the form of either it's a newly onset constipation coming up, or the person has got an hematochezia, or the person has got an obstructive symptoms, if the person has got a family history of cancer, then of course, we should have our antennas coming up properly. And we should really find out and do a simple thing which normally all of us would like to do, is a colonoscopy. After doing a colonoscopy, if you don't find anything, fine. If you really find something, sorry, then you need to be treating the person accordingly, what absolutely is going to happen to the patient. And of course, ultimately surgeries to find out the transit part of it, we do a deficography, we do basically scintigraphy and other things. Many drugs which all of us remember, but at times we forget in our day-to-day practices, that which are the drugs which basically cause more of constipation, like analgesics, antispasmodics, antipsychotics, we all know. Because our psychiatric friends usually they keep on doping the patient, and giving at least 3 to 4 to 5 antipsychotics so the person doesn't complain. And that leads to constipation. Iron supplements, they do cause diarrhea and constipation. Both opiates, we all know, antihypertensive drugs, zinc alkaloids, that is basically your agents which are being used for treating cancers like vinblastine or other things. So friends, after this overview, I think we know that because as we have got lot many things, so constipation of course can be cured. And what are the treatments? There are two types of treatments which we all know: a non-prescription treatment and a prescription treatment. Non-prescription treatments are our Google Baba and the YouTubes and the knowledge which comes from our friends and foes. And prescription treatments are the real ones, which are there in the form of drugs, which we should know whether what exactly we are giving. Whether it's a 5-HT antagonist, whether it's interstellar secretagogue, or we are giving the new ones, which are called as the GCC agonist. So multiple drugs we all know are there, like osmotic agents, the stimulant laxatives, and the surfactants. I think they're all very much well known to us. And the drugs which are there available are levosulfuride, lebiprostone, prochloropride, and the two new armamentarium drugs which are there in the market now very soon. One of them is very much there, that is plecanatide. Tegaserod we were using has been withdrawn. Misoprostol is not much of a thing. Colchicine in fact is no more used nowadays. So to start with, normally everybody says, all of us are being taught one, and the foremost thing is that you need to have something called dietary modification, that is the bulk forming agents. And good amount of fiber in your foods. Multiple fibers here have been enumerated, which we all know that what exactly one should take, like more of vegetables, more of legumes, more of things like breads and butter, but avoid butter things. You can have fruits which are having good amount of fibers, and of course try to avoid the real maida which comes to you, which causes constipation in the form of every nick and corner we get momos and chow means. So dear friends, if you know that a person is constipated, if we know that the constipation can be cured, but ideal thing should be at least one, try to first of all examine the patient. We try to examine the patient by putting a scope inside, but hardly see what exactly is happening, like an inspection of the anus and the surrounding tissue. By testing the perianal sensations, which are very much important. Of course, what we normally forget is to do the digital examination. If you don't put your finger inside, then put your, that's a saying you all know, I need not say it once again. So we try to see by doing the digital examination whether there is a tenderness inside, a mass or polyp or a stool consistency, the resting tone of the sphincter, whether the person is able to do a squeeze maneuver, whether you can really push out and do the bearing maneuver part of it. So if there is a defecating disorder, there has to be something we need to do, and this is the defecating disorder, and most of them are basically because of the pelvic floor dysfunctions. So multiple things are being done. To enumerate the same thing again, either you go do a manometry, anorectal manometry, you do a balloon expulsional test, and so on and so forth. So what are the available treatment for constipation as on date? We all know that psyllium, that is your isabgol, that husk is very much available. You have got lactulose, you have got sorbitol, you have got milk of magnesia and other things. Lebiprostone was very much there and is still there. And of course, try to say to your patients very clearly that they should not use a freely available drug, that is bisacodyl and prochloropride. So friends, there are lacunas in the management of constipation, but what's the way forward? So we really need to meet the unmet needs, and in day-to-day practice we need to see two things. Either it's an IBS-C or the person has got a GIC. So use of pharmacological agents, we all know which ones to be used. Some of them I have enumerated. The latest one available to us is your guanylate and uroguanylate. These are small peptides which are normally found in the luminal surface of epithelial cells linings of an intestinal tract, and their basic interest is that they are potassium hydrogen receptors, where they don't allow the things to come up and they cause secretion, stimulation of your intestinal chloride into the intestinal lumen, and in order to make your constipation better. This is where the the diagram is. And GCC, the indication basically is either constipation in adults as well as in patients with IBS-C. Contraindications only in the younger age group, and of course it is not safe in pregnancy, but it can be used in any subjects above 18 years of age and in all elderly patients without changing doses, as is being done with procalopride, where you usually say that after the age of 60 years one should only give 1 milligram of it a day and not 2 or 4 milligrams. So the place here is that after your dietary lifestyle modifications, after giving your other laxatives, if the person doesn't have and is still refractory to the constipation, then of course the place of GCC comes into action. 2 drugs available, we all know, linaclotide and plecanatide. Linaclotide is still not available into the market. It comes in 2 forms of 145 micrograms and 290 micrograms in the Western world, and plecanatide comes in 3 and 6 milligrams, and 3 milligrams is absolutely available in the market. And of course, as it has come into the market in the last few months, my personal experience says that it's a wonderful drug. It works, though it is a little bit pinch to the pocket. Hardly any adverse effects. Diarrhea usually comes up, and flatulence or abdominal tenderness doesn't have to be worried about. There is not much increase in AST-ALT levels at all. So the efficacy and safety studies of plecanatide are wonderful. This drug has been used nowadays widely both in the West and now of course with us in the Indian market. And up to 72 weeks you can use this drug. I've used it for 12 weeks without any problems. So people have been doing very good on this. And it doesn't have any worrying adverse effect at all. So once it's said that it is a well-tolerated drug, in elderly patients it really works wonders. This is certain, the things, sort of comparisons between the plecanatide and the fibers. Plecanatide as well as tegaserod, which is again not available with us. Plecanatide with lubiprostone. Lubiprostone usually, if it doesn't work in 3 to 5 days, one usually tends to stop it, whereas the other things do not. Just a minute. Plecanatide versus procalopride, the only thing is that in procalopride you have to be a bit more careful in early patients, not increasing the doses. And both the drugs are FDA approved, of course. These are the papers, we show very clearly that this new armamentarium which we have got with us is a lovely one. And of course, as we don't have anything else to do, so one has to do this. It has been recommended by AGA, it has been taken over by the British Society. For anorectal dyssynergy, we normally, as I said, we do anorectal manometry. And for that, there are criteria for dyssynergification, seeing that either you give a person to propulse a balloon or an artificial liquid which is normally there, and we need to see whether the person has got an inability to expel or not. Biofeedback is one thing which usually is done if a person does not want anything. This new thing is almost heard everywhere, that ab kuch nahi kar sakte to kya kar. Then you have got this thing coming up. All good institutes have got a biofeedback technicians who are there being trained very nicely by gastroenterologists only, and then you can really get something out of it if no drugs work on it. So the expectations of a patient is that that if you got a persistent symptom, is there any treatment? Yes, of course. After such number of drugs which are there in the market, there are drugs. And do you really think that plecanatide fill the gap? That time is going to tell us. Thanks a lot for your patient hearing. Anything, sir, we can clarify.
Nice and simple talk, sir. My query is regarding osmotic laxative of choice in patient with slow transit constipation, number 1. And number 2, as you said, in elderly, procalopride more than 1 mg can be
Should not be.
disaster, should not be.
Should not be given. That's because of the cardiac side effects.
Okay. In that case, adding newer drugs with procalciferol, does it help?
Sir, there is no head-to-head study with pleclumide and chloride to be given, because pleclumide is a drug which is given only once you have been getting no effects because of the other available drugs in the market. So this is one thing, which acts through the chloride channel system by increasing the secretions into the intestinal lumen. So good amount of fluid is in, which gives you a better option. As you said about the
Slow transit constipation.
slow transit constipation, sir, this is one thing which is absolutely considered to be a normal one, where our intestines usually don't work. While doing a colonoscopy, most of my gastroenterologist friends will agree here that what happens here is that you normally must be seeing a report called redundant colon, where normally it is written that it was very difficult for you to enter up to the cecum and terminal ileum because there was no proper movements of the intestines coming up. And these are the people who are having this slow transit where there is no organic cause as it is with them. And as you said about the osmotic agents, the one which is the best out of all these 4 or 5, which is enumerated, is the PAG, that is polyethylene glycol, which is the one which acts better. Now you get both in the form of sachets, and don't take the pre-ready liquid to be given to the patient, which usually doesn't work. It has to be freshly made before giving.
So one subset of patients that are really difficult to handle are patients who are having chronic laxative abuse. How to approach them? Because they keep on increasing we keep on increasing the dose, adding the drugs, but still the patient.
Sir, that abuse has been started by the patient himself.
And they are resistant also.
So
they
have to be, sir. That is the reason where you normally see one more diagnosis in colonoscopy called melanosis coli, which usually happens, you see that something new I found out in the colonoscopy in the form of a different color of your colon. It becomes more blackish and brownish. It's all because of the chronic laxative abuse, and thanks to our social media and the TV, which is giving us so much of nonsense, those ads where there is nothing, which can be done to stop. Patient आपके पास जब आता है तो he has already taken, at least 3 to 4 type of drugs on his own. So one thing which is more important in our country is that, as happens in the Western world or in the European world or even in the Eastern world also, in Japan and Korea, you don't get drugs available, through a pharmacy just like that. You walk in and take it. So until unless these things are stopped, this abuse is going to continue. How much you feed them?
One question.
Sir.
When you advise colon transit study in a patient of chronic constipation, when the patient first comes to you, when you titrate some of the medications after a few weeks, when you actually advise the patient colon transit studies or initially...
Or a scintigraphy or a defecography, yeah. Whatever. Sir.
Yeah.
Sir, it is usually done in patients until unless the person has been properly evaluated. It is not that the person comes to you for the very first time and then you start asking the patient to go for a study. History is important, how long it has been there, whether it is for months or years together. If a person has already taken the drugs in the form of either a bulk forming agent or an osmotic ones, or the person has taken a stimulant laxatives and the available drugs in the market, if they are not working, then obviously you are supposed to do a transit study, which is being done in the form of scintigraphy. But Amar Mukund is here, he can easily give us that what exactly they do. It's a capsule which is done, which has got around 24 radiopaque markers, and then you study that after 24 hours how many of them have been brought out, and after 122 hours how many have been brought out, which basically decides that the person has got a sort of a slow transit one if the person's colonoscopy is absolutely normal. If there are no questions, thank you.
Thank you so much for the wonderful session, sir. Next, I'd like to request Dr. Amar Mukund, sir, to come upon the stage to share light on BJISGCON syndrome, imaging and intervention. Dr. Amma Mukund sir is a popular faculty in ILBS and professor of interventional radiology. He has special interest in hepatobiliary intervention, and today he'd be sharing light on Budd-Chiari syndrome, imaging and interventions.
Thank you so much for the kind introduction. At the outset, I would like to thank organizers, especially Dr. Jayant, for having me here. So, just changing the gear, coming to a different arena where actually interventional radiologist plays a important role in treating a disease. So, Budd-Chiari syndrome is a common disease even in this area, and especially if we go to Nepal and eastern part of the India. So it's very common and many time missed. So we should know like what all to look for and how do we diagnose, and finally once we make a diagnosis, what to do. So what is actually, it is characterized by obstruction at the level of either hepatic vein, IVC or right atrium. So wherever the outflow is compromised, it will lead to Budd-Chiari syndrome. Extremely sorry. Yeah, so nothing to disclose, and as I was talking, like it is an obstruction of hepatic venous outflow, maybe at the level of hepatic vein, maybe at the IVC, suprahepatic IVC, or maybe at right atrium. So sometimes we have cardiac causes which may lead to symptoms which is very much similar to Budd-Chiari syndrome. And there are two forms of disease. Not from my side, so I haven't placed any such music in this presentation. So anyway, two forms of disease are recognized, the acute and the chronic HVO2, and rarely we find acute disease. So acute disease is not so common in Indian subgroup, and mostly it is seen in patients who are taking OCPs, steroids, or maybe postpartum females. They do present sometimes, but what we see in India is mostly acute on chronic, or acute on subacute variety of disease, not exactly the acute one. The acute one are actually very difficult to manage. They come in a severe situation and they deteriorate very fast, and they need to be acted upon immediately, else it is very difficult to save those patients. And if we talk about what we actually see is chronic or maybe subacute. So subacute is another variety which we see very common. However, the most common is the chronic one, where we see membranous or fibrous obstruction of hepatic vein and IVC, and sometimes they may present as a patient of CLD. So whenever we see a young patient of CLD, we should always keep one of the differentials as hepatic venous outflow tract obstruction, though the recent nomenclature by Bavino and other Western countries have actually said that we should rather use Budd-Chiari syndrome than HVO2, but in India still HVO2 is commonly used. So when do we suspect HVO2? Whenever we find a fulminant liver failure with abrupt onset of ascites and hepatomegaly, and there are no causes. So if you don't find any causes like viral hepatitis, alcohol abuse, or any other underlying factor, then definitely one of the differential would be HVO2. Massive ascites with relatively preserved liver function. So again, liver functions fine, ascites, so one of the differentials. Unexplained chronic liver disease. There is a diagnosis of chronic liver disease, but you don't know the cause. Liver disease with an associated thrombogenic disorders. And definitely, yes, whenever you see a visible abdominal and back wall collaterals with ascites or upper GI bleed, so these are the patients should definitely be asked the radiologist to look for any signs of HVO2. So what does the imaging do in such kind of patients? How does it help the patient? So it plays a very important role. In fact, imaging is sufficient to make a diagnosis, and we don't need a biopsy to prove Budd-Chiari syndrome unless until there is a equivocal cases. And what are the key to the diagnosis is a strong clinical suspicion. So as you all would actually see these patients meticulously, and definitely you will come to a conclusion, yes, there may be a Budd-Chiari syndrome or HVO2, and accordingly radiologist may be asked to look for signs of Budd-Chiari syndrome. Then what radiologist should do, meticulous USG and Doppler examination. That's the most important, and one of the best tool to actually assess a Budd-Chiari syndrome. So coming to ultrasound findings, so what do we see? So if you see here in this slide, if you see this is a membranous obstruction, so there is a cutoff, and this is how it sees. So it is a small short segment occlusion of hepatic vein. Then you may have a thrombus. Here you can see a thrombus sitting here. Sometimes in chronic form you can see complete obliteration of hepatic vein. So this hepatic vein is not seen. So this is how it looks. And in further advanced cause, you don't see any hepatic veins replaced by multiple tiny collaterals. So you can see only collaterals, no hepatic veins. So these are the signs. And sometimes if you see the literature, you will find something mentioned as comma-shaped collaterals, and this is how the comma-shaped collateral looks. And there is a caudate lobe hypertrophy. This is a caudate lobe hypertrophy, and then you see a enlarged caudate vein. Then you may have ascites, no flow, and moving to CT finding. Suppose there is a suspicious finding on ultrasound and somebody is still not sure, he will write, there may be a Budd-Chiari syndrome. So what do we find? So in acute Budd-Chiari syndrome, you will find a central predominant enhancement. So the enhancement is mostly seen in the central part of the liver, whereas the peripheral you don't see. There is large ascites, it is tender hepatomegaly, and the bilirubin is rising and patient is deteriorating every day. This is how it looks. You see the central area, only the central part. Basically, these are the area which have their vein patent. So caudate has a separate vein which remains patent. That's why you have a normal enhancement in the caudate area, whereas the peripheral part doesn't show any enhancement. Then there is a subacute form, which I was telling, which is more common, which we see more commonly. And you see such kind of mottled appearance in the subacute form. And you may also find portal vein thrombosis. So sometimes you find that there is thrombus which is extending into the portal vein, and these are the patients which should be intervened immediately, else even the portal vein will thrombosis, and it will be very difficult for any person to do a intervention in such kind of patients. Then is the chronic Budd-Chiari syndrome, which looks very much similar to a cirrhotic patients, so almost looking like cirrhosis. And if radiologist is not aware, probably he'll mention it as a chronic liver disease rather than a Budd-Chiari syndrome. And then you can see multiple lesions in such patients. You have arterially enhancing nodules, which is known as nodular regenerative hyperplasia, or nowadays it is known as regenerative nodules of Budd-Chiari syndrome. And you can also have HCC in Budd-Chiari syndrome. So previously, it was believed that in Budd-Chiari syndrome, we generally don't have HCC. But now we have seen that HCCs are not uncommon in Budd-Chiari syndrome, and we pretty often find in a long-term follow-up that these patients do develop hepatocellular carcinomas. So moving to the next part. So once we have made a diagnosis, then we need to intervene and we need to treat these patients. But again, the question arises, and there is a huge debate which patients would require treatment, because many times these patients are asymptomatic, and there is always a debate that there would be some people who will say they doesn't need a treatment, and there would be a group of patients who will say once the diagnosis has been made, it should be treated. So simple dictum, all symptomatic patients should be considered for a IR management. Why I say IR management? Because these are minimally invasive treatment, just short of a medicine. So initially you are using a medicine, but here you are trying to do it angiographically with just needle, guide wires, and probably a balloon. So any symptomatic should be treated, and asymptomatic patients with recanalizable hepatic vein. So now coming to what happens to asymptomatic patients, those patients who are asymptomatic but the normal physiological outflow can be restored, those patients should also be treated, because you are doing nothing wrong, because he already has a IVC or a hepatic vein which is occluded. So if you can simply open it without a major procedure, just putting a guide wire, balloon, and opening it, they should be treated, because it will prevent further deterioration of the liver and development of cirrhosis in these patients. And patients with fulminant liver failure, so now there comes a patient who have a fulminant liver failure, they should be considered for an emergent liver transplant. However, emergent liver transplant is not possible in all patients. So again, here rescue tips or dips should be done to prevent deterioration of liver function. Probably they will need a transplant at some point of time because there would be enough necrosis in the hepatic parenchyma, but it can act as a bridge. Maybe it will give you some more time, a couple of months till the patient gets a transplant. And for some patients are fortunate, like if they get tips at time, probably they may not need a transplant also. So these are the patients. This is how we can actually plan the treatment. And what is the algorithm for treatment? So there are three group of patients what we see. Previously, if we go through the data which was coming in 70s and 80s, so membranous occlusion of IVC, so interrupted IVC was the most common thing what we were seeing. So everything was patent, only IVC was blocked. Then other group which was more reported from the western side, that hepatic vein is occluded. So second type is where IVC is patent but hepatic vein is blocked. And the third variety where everything is replaced by small collaterals. So no hepatic vein, native hepatic veins, there are many small collaterals. However, IVC may or may not remain open. So how do we treat? So the first one, you just need to open the IVC, do a balloon angioplasty, maybe you can place a stent. Second group, that is the hepatic vein, again you need to open it, but these are small veins, so probably you need to place a stent. In IVC angioplasty, stenting may not be done, it can be avoided, but in hepatic vein, mostly stent would be required. What happens to this third variety, the third one, where we don't have a recanalizable hepatic vein? So actually a shunt has to be created. Like previously, surgical shunts were being created. Nowadays it is, transjugular intrahepatic portosystemic shunt or direct IVC to portal venous shunt. And just quickly show you some of the cases. This is one of the case with IVC, membranous obstruction of IVC. If you see carefully, you can see a membrane over here. And this is how it looks over here. And these are the azygous veins, which is actually bypassing it. And simultaneously, the patients have a vein in abdominal and back wall. This is how it looks on angiography. And you can see over here. And this is what we do. We take a balloon, we dilate the tract, and finally you get a good flow through it. In the hepatic vein variety, you can again see we try from the jugular side or the femoral side. If we fail, then we directly puncture the hepatic vein, go into the hepatic vein, take a wire into the IVC, snare it out, and then we do a balloon dilatation and place a stent. And if nothing is possible, like in this case, then we come from the top, from the jugular root, we puncture the hepatic parenchyma, puncture the portal vein, take a wire across, and then place a stent, and you create a shunt. And this is how you relieve the congestion. This is one of the algorithm which we have presented how it should be done, and we published it. And not going into the detail because there is limited time. So coming to the last part, how do we follow it up? We need to do a regular Doppler for these patients to look for patency of the shunt created or the hepatic vein which has been recanalized. And whenever you find an occlusion, you need to actually treat. Sometimes you find there is a recurrence of symptoms, but Doppler says that it is patent. Then it is better to go for a CT scan. On a CT scan, you may see some thrombus sitting in the wall, which is actually compromising the lumen. And again, you can go inside and do a balloon angioplasty, and probably the patient will again improve and symptoms will disappear. For tips, again, if there is a block, you can recanalize, get inside, and you can clean the tips stent, do a thrombectomy, and finally open it up. So with this, I come to the end of my talk. A clinical suspicion and a meticulous ultrasound evaluation remains the key to the diagnosis of Budd-Chiari syndrome. CT and MRI helps in confirming the diagnosis and depicting the perfusion and venous pathways. And interventional treatment of symptomatic Budd-Chiari syndrome is based on restoring hepatic venous outflow to decongest the liver either by recanalizing the hepatic vein or IVC, creating non-surgical portosystemic shunts, that is direct intrahepatic IVC to portal venous shunt. Thank you so much for your patient hearing.
Very nice and crisp talk. One question, where do you place the role of anticoagulant pre-tips and post-tips?
So in case there are no high-risk varices, and probably if the patient can be taken up at some other point. Maybe the expertise for tips is not available. So the anticoagulation should be started in those patients. But if there are high risk varices, then probably it needs to be ligated first, and tips may be done. But in centers where the facility for tips is already present, so it is always better to do transjugular the tips procedure or a dips procedure, and then the patient can be taken up for anticoagulation, because once we do EBL, then after that is you need to wait for 21 days, and then finally you can start anticoagulation. So those are the things. But in case we find that these are varices which can be ligated and patient is otherwise asymptomatic, we ligate it and start anticoagulation. And anticoagulation should be for lifelong. Again, there are many regimen for anticoagulation. You can use acetrom or maybe the newer one dabigatran. So many things to be decided, and it depends on how monitoring is to be done, where the patient is from the same city or maybe from outside, what is the affordability. So there are many factors how we consider that.
Sir, once IR treatment has been done, then how to follow those patients? How frequently you would like to see, and how frequently us as a gastroenterologist should monitor those patients?
Yeah, so that's the key to the long-term success. Once the treatment has been done, it should be seen initially maybe within 2 weeks to 3 weeks. Then monthly follow-up for a couple of months, maybe 1 or 2 months. And if everything remains patent and patient is a compliant patient following all the anticoagulation protocol as said, there is a disappearance of the symptoms, then probably 3 monthly and maybe 6 monthly. So 3 to 6 months depending how the patient is comfortable going for an ultrasound, because we generally prefer just to do an ultrasound, and maybe simultaneously endoscopy may be done, because sometimes on ultrasound you find that whatever has been treated is looking good, but the patient may show development of some varices. That means again there is some occlusion or there is some congestion, and which is leading to portal hypertension and finally formation of varices. So endoscopic survey should also be done periodically, maybe 6 monthly or at least annually, if not more early.
So in Bud Chiari, after decompression, regarding my question is regarding HCC, does decompression help against HCC, number one, and number two, should we start screening BCS patient with regular HCC screening with alpha fetoprotein or?
Yes, so that's a very important question actually. Thank you so much for putting that question across. So those patients who are treated early, that's why I said wherever there is a recanalizable hepatic vein, still the patient is asymptomatic, we should actually open the hepatic vein. You are making it physiologically normal. He was in an abnormal state where it has been occluded, and you open it, maybe IVC, so you can open it. So those patients generally have a lesser grade of fibrosis. In fact, I didn't put that slide. So we have made an algorithm. People actually are not happy doing biopsies for these patients, but the time will come when everybody will say, okay, if biopsy is safe, why not to do a biopsy and actually see what is the grade of fibrosis. And why we need biopsy is because fibroscan is not going to give us the actual estimate of fibrosis in these patients. These are congested liver. So if fibrosis is low, you treat it, there are no chances of hepatocellular carcinoma. But if you treat a patient who already has developed fibrosis at maybe above F3 state, then they may develop. And those patients who get STIPs, they can get HCC even after recanalization. But normally those who have physiologically opened like IVC or hepatic vein, generally they don't, because in our experience we have seen at least 2 patients who underwent TIPS were doing very good, but they developed HCC at some later point of time. But in last 15 years I haven't seen any patient who got his physiological recanalization ever had any HCCs. But yes, we are seeing HCCs more often than what has been reported previously in the literature.
2 questions. We know this disease is more common in female. Any hormonal imbalance or any statement?
Yes.
Second, when there is indication for surgery in this case?
So yes, female is mostly because of hormonal. In fact, we see many patients coming with steroid intake. So young male also, especially those young persons who are very enthusiastic and want to have a very early bodybuilding kind of a thing and muscle mass, so they go to gym and they take steroids for muscle building. So we pretty often see, and female also. So the female, what we see is mostly acute or subacute variety, whereas there is another low socioeconomic strata group which typically shows Budd-Chiari syndrome, maybe asymptomatic, actually coming just for bloating or some ascites, or first time presented as a bleed. So those are chronic Budd-Chiari syndrome, and when we see these group of patients, these are low socioeconomic strata, we still don't know what are the factors which leads to such kind, and that's one of the reasons why we see it is more in the eastern belt, probably in the Nepal as well. So these are the age. And as far as surgery, whoever can decompress the system, but because these patients present late and many times they have a high portal pressure, may not be fit for surgery. But at expert center, maybe PGI is one of the center which still does some of the surgeries, bypass surgeries for Budd-Chiari syndrome. So if a surgeon can do a very good job, why not? But it still becomes a more invasive procedures where you have to do a major laparotomy and then create a shunt. So where such kind of shunt can be created just by guide wires and catheters. So this is how the treatment paradigm has changed. But wherever the facility is not available, I think surgeon can do a very good job, and they should take it.
Thank you, sir. Thank you. One question regarding the diagnosis of the Budd-Chiari syndrome. The radiologist must be very cautious while doing ultrasound of a patient of cirrhosis of liver with unknown etiology. The question is, how many patients do you see having Budd-Chiari syndrome in your hospital when they come for undiagnosed chronic liver disease or cirrhosis of liver?
Sir, this is not uncommon to see, and you have a very valid question. In fact, last time also you discussed something regarding collaterals. So yes, I take this as a challenge where we need to train our radiologist colleague as well. They should be able to pick this disease, especially those areas where it is very common. And yes, these are missed. When I was in SGPGI, I used to see again many patients who were undiagnosed case of CLD, and finally we got to know, okay, it is Budd-Chiari syndrome. Similarly at ILBS, yes, we see many patients who are being treated as an autoimmune, because many times you will find some of the soft autoimmune markers positive, some being considered as Wilson's or whatever. So there is so many differentials, and they are just being treated as a CLD patient. So yes, it is missed, and probably one should actually give some more time while doing an ultrasound rather than just looking at the ecotexture and calling it a coarse ecotexture and CLD and portal hypertension. That is the easiest thing to do, and just send a report to any of the treating physician.
One comment or extension of the our radiologist colleagues or radiologist organization must be told that while doing ultrasound of the liver, they must mention hepatic veins and IVC. They don't see the hepatic veins, they don't see the IVC, they give the only report. The treating doctor is always in a problem while treating such group of patients.
So there is some difficulty because these liver are mostly shrunken or maybe small, and it is difficult, and patients are unable to hold breath. So it takes time, and everybody is busy with so many patients. So everybody wants to do patients very early. So that's one of the reasons why we are able to pick, and why somebody is not able to pick is it is just about giving 5 extra minutes to look at those points.
So my question regarding the role of anticoagulant. In actually contrary to common belief, in patient with liver cirrhosis, the anticoagulant therapy actually decreases the chances of variceal bleeding and variceal progression.
So yeah, point very well taken. Actually, that's a very controversial topic, and actually an upcoming topic. So yes, anticoagulation does not lead to bleed, and that's why in all the guidelines wherever we are treating portal vein thrombosis, anticoagulation is being prescribed. But it is again a double whammy. Sometimes if those patients do come with a bleed, they bleed torrentially. But we haven't seen any such bleed, but as per the belief, it is how it works. And many times it's experts' opinion which are taking a call. We don't have level 1 evidence to actually prove such kind of things. So these are real world scenario. So what you said is absolutely right. Yeah, I agree with you. But with portal hypertension, red color signs on endoscopy and other telltale factors which may determine a future bleed, we should be cautious.
I think we as gastroenterologists should not write just ultrasound abdomen in any case of liver disease. We should specify ultrasound abdomen with Doppler of splenoportal hepatic vein axis. If we write that much, maybe it will force the radiologist to comment on that, because otherwise it is just a routine case and they don't comment on the Doppler findings.
Actually, the Doppler the extra cost, they charges extra cost to do Doppler examination.
No, for that we can just write a strong clinical suspicion of this, kindly rule it out. Probably that will help without increasing the cost. Thank you, sir.
I'd request all the speakers, Dr. Amar Prem, Dr. P.K. Agarwal and Dr. Amar Mukund sir, to please come on the stage for felicitation. And I'd request chairpersons to kindly felicitate our speakers. Now I'd also request Dr. Amar Mukund sir and Dr. P.K. Agarwal sir to kindly felicitate our chairpersons. Thank you to the speakers and the chairpersons. Chairperson for the next session are Dr. Sanjeev Kumar Jha, Dr. S.R. Chakravarti, Dr. Ashish Kumar Modi and Dr. R.R. Sinha sir. I'd request all the chairperson to kindly come up on the stage. Next, I request Dr. Rakesh Kumar to please come on the stage to share on the light of management of IBD. Dr. Rakesh Kumar sir.
Good morning, everybody. And at the outset, let me thank the organizers, especially Dr. Chandan and Dr. Manohar, for inviting me for this lecture. I'll be speaking on the management of inflammatory bowel disease. And since there were 3 speakers on this topic, so I have modified my talk. I don't know whether those lectures are coming or not. So basically, I will be dealing with how do we manage a patients of IBD when we first see it in the clinic and their journey through the disease. So it's a chronic, relapsing, remitting, inflammatory disease of the GI tract. And why do we need to manage these patients? So this is what has been shown. 1955 was the year when the treatment of IBD started. It was Truelove and Witts who first time used corticosteroids. And before that, this disease, the mortality was as high as 40%. And after the use of steroids, it decreased to almost 8%. And subsequently, with the new therapies coming up, the mortality has been coming down. And you see how the disease has shown low mortality, and with the new colectomy, when it started, the mortality even touched around 2 to 3%. And this is the same rate. The probability of colectomy has also come down with the newer treatment. And we see after the biologics, the surgery rate has come down both in the ulcerative colitis and in the Crohn's disease. This is the data before 2000 and after 2000. Actually, in 2000, the first report, 2001, infliximab came. That was in 6 patients. And thereafter, many biologicals and small molecules have come. And we see how the rate of surgery has come down over 1 year, 5 year, and 10 years in these 2 groups. That is why we need to treat such patients, because we see the mortality coming down with the new therapy. We see the rate of surgery coming down with the new therapy, and also there is a lifetime risk of colorectal cancer in these patients. And this risk increases with the duration of the disease, reaching as high as 18 to 30% in patients who survive with disease for more than 30 years. Chronic, this is more in the ulcerative colitis, but in the Crohn's also more or less the same data is there. So while treating such patients, what is our goal? So the goal is very clearly defined, that we have to achieve normal bowel function, which is defined as less than 3 bowel movements a day, well-formed stool, no blood, rectal sensation should be there, and patient should be able to discriminate between the gas and the fecal content. And there should be improved quality of life. If we can achieve this, then we are treating the disease well. And there are 3 pillars of this treatment, management, both in ulcerative colitis and Crohn's disease. Early intervention, treat to target, and tight control. Why do we need all these things? Because early intervention, treat to target, and tight control. The treat to target and tight control has come up in last few years, maybe last 10 years, when we are also looking for deep remission. I will go into the details later. So the first thing, before we intervene, the first thing we have to do is to diagnose the disease. When a patient comes to us with a history of blood mixed stool, we have seen there is a delay in the diagnosis of IBD. And it is world over. Normally, ulcerative colitis or Crohn's disease is diagnosed after about 2 years of the presentation. First patient being symptomatic, the patient is diagnosed with the disease after 2 years. And even in the Western world, the average delay is around 10 months. And this delay is not, and this early intervention means we have to diagnose it early. We have to have a high index of suspicion, and that is why clinical part comes in, and we should know when to suspect this disease and should go for endoscopy with histology. That is the cornerstone of diagnosis. Radiology may help, especially in differentiating between the subtypes, whether it's Crohn's or whether it's ulcerative colitis. At times it may be difficult endoscopically, and also serum biomarkers. There are different biomarkers which help us, like fecal calprotectin, CRP, because sometimes what happens that we have to differentiate between organic and functional diarrhea, then the FCP may be of help. Also, ASCA, that is anti-Saccharomyces cerevisiae antibody, P-ANCA might help. Here, ASCA and P-ANCA usually help between two different differentiating the types of the IBD. So our first goal is to diagnose it and then differentiate whether we are dealing with ulcerative colitis or Crohn's disease. At times, it could be unclassified. We may not be able to diagnose the disease at the first instance. And also, we should be aware of the mimics. Some of the diseases which also look like IBD but are not IBD. Here you see the picture which is almost like Crohn's disease, but it is a CMV colitis. Similarly, this is nowadays we have many biologicals being used and different advanced disease treatments being used in cancer. This is immune checkpoint inhibitors being used in a patient of metastatic melanoma, ipilimumab, and you see the pictures. Both are the same patients, the same drugs, giving pictures of Crohn's as well as ulcerative colitis. So it mimics almost like any IBD. It could be Crohn's-like picture, it could be ulcerative colitis-like picture. So the history taking is important, and the background in which you are diagnosing this disease. Then you have radiation proctitis. Sometimes you may get confused. Behçet's combined variable immunodeficiency. These are various rare causes which may mimic IBD. So you have to be aware of these differentials to diagnose IBD. So how do we intervene? Early intervention means what do we do? So our first goal is induce remission. Induce remission means we have to achieve clinical remission, we have to achieve endoscopic remission, and also histologic remission if possible. And then we have to maintain this remission. Because why is it important? Because once we achieve remission, then the inflammation is controlled, and the maintenance of remission, control of inflammation over a longer period of time prevents relapse of the disease and its progression. That is why this is very important. And we have seen how the therapy has improved over years. We now have many agents. Earlier we used to have only steroids and 5-ASA. Then azathioprine came. Then there was cyclosporine, infliximab, vedolizumab. There are so many drugs now available. So now the confusion has increased. Which drug to use when? And this is very important. How do you decide which patient would require which drug? So you have to decide the activity of the disease and also the prognostic factor, the risk factors, severity. Activity is a cross-sectional view. Patient comes today, you decide whether the disease is mild, moderate, or severe. That is his conditions today. And then you see the risk factors of his developing complications requiring colectomy, requiring frequent admissions, or need for advanced therapy in future. And this will depend also on various factors, like young age, both in ulcerative and Crohn's disease, less than 30 and 40 years of age, because they are going to live longer. They will suffer more from the disease. Then the extensive disease. In ulcerative colitis, it could be extensive colitis or pancolitis, and in Crohn's, it could be beyond terminal ileal involvement, perianal involvement, stricturing, penetrating disease. Then you have severe endoscopic findings. In the first instance, you find that the disease is severe. And third, like various superimposed infections like Clostridium difficile, CMV, extraintestinal manifestations, prior use of steroids, prior admissions, and prior use of biologicals. These are all risk factors. If you find your patient who has a milder disease today, but he's young, then you may think that he may develop complications tomorrow. So he has a risk factors. So you have to basically decide between these two also, that whether what is the severity today and how he is going to behave in the future. And based on these two parameters, you decide which therapy will be more suitable for that patient. So if we assess that the patient is mild to moderate UC, then 5 ASA, and he is a low risk. Low risk means he does not have all these risk factors which I enumerated. Then 5 ASA is the cornerstone of therapy. That is mesalamine, both for induction of remission as well as the continuation of treatment, that is maintenance of remission. But when you start a patient on any therapy, you should be aware that whether therapy is working or not, and you should see it within 4 weeks. The therapy should start working. If it is not working, then you should change your course, and that is very important. So, and suppose you have used steroids for remission in mild to moderate UC, then what do you do next? For the maintenance therapy, patient has achieved remission, do you go to 5-ASA, do you go to azathioprine, or you continue with steroids? Of course, steroid is never used as a maintenance therapy, and that is the primary goal of maintenance of remission in ulcerative colitis or Crohn's disease. So what we do, we can go to 5-ASA if it has been mild or moderate to start with in a low risk scenario. At times we may also use azathioprine. But suppose a patient, you have started with 5-ASA, he has achieved remission, you are maintaining on 5-ASA, and then he recurs, he relapses, then you have to modify your disease. Similarly, if you have used steroids for induction, and then you go to maintenance with 5-ASA and patient again relapses, don't cycle between steroids and 5-ASA. You have to go to the advanced therapy. But basic parameter is the agent which induced patient's remission has to be maintained, has to be used in the maintenance, except for the steroid. So now this is for the mild to moderate, but for moderate to severe category and the riskier groups, what do? We have to choose advanced therapy. And these are the advanced therapies like anti-TNF, anti-interleukin ustekinumab, mirikizumab, anti-integrin vedolizumab, JAK inhibitors, tofacitinib, upadacitinib. There are so many, filgotinib, S1P receptor modulator, so ozanimod. These are the things, and even surgery. So how do you choose? So you have to see patients here. You have to see what are the coexisting conditions, which agent of these is available, the cost. Here in India we have limited choices, but if given a scenario where we have everything available, then you have to see what are the common associated immune problems like atopic dermatitis or psoriasis. Then your choice would be anti-TNF, JAK inhibitors, or anti-IL-23. But suppose if he has axial arthropathy, joint problems, then you would rather prefer anti-TNF and JAK inhibitors because it will take care of both the things. If your patient is pregnant, what do you do? Or is going to be pregnant, so is planning pregnancy. Of course, you will not use the small molecules. That is your S1P receptor modulators and JAK inhibitors. And this, if the patient has used 5-ASA, but he has relapsed, then you can also use JAK inhibitors straightway to maintain the remission. And surgery is one of the choice that should always be kept in mind, because this has been shown in various studies now that patients undergoing ileocolonic resections do very well subsequently, and you should not give surgery for the last. And these are the landmark trials in UC, which I will not go through. And the third point is how to maintain the remission, how to make patients treat to target. What is the target? Target is decided between you and the patient. Earlier the target used to be symptom remission. Patient was free of symptoms, he is happy. Now this is not true. You have to have the endoscopic remission. Mucosal healing should be there. And if possible, even histologic remission, that is on the histology also, patient should be doing well. And for this you have various parameters. You can monitor endoscopy, biomarkers, therapeutic drug monitoring, CRP, fecal calprotectin, and also these anti-drug antibody would help in deciding. And this is what it says in a nutshell, that if you are not achieving your target, you have, means the disease is active and you have to go back, revise your therapy, change it to other therapy, other group of drugs, use other group of drugs. And sometimes you have to de-escalate also. If the patient is into a stable remission, you de-escalate. De-escalate doesn't mean you have to take him off the therapy, high dose of mesalamine to low dose of mesalamine. A steroid to steroid sparing is also de-escalation. And if you are using infliximab with immunomodulator like azathioprine, you take off azathioprine and just continue on the biologics. And this is what is to be done. And subsequently, you have to monitor these patients for colorectal cancer prevention, and that is in patients who are more than 8 years, who has been with the disease for more than 8 years. Then you have to start a screening program. I will not go into the details. And depending on the findings, you have to decide whether there is dysplasia, whether adenoma, multifocal, low-grade dysplasia versus high-grade dysplasia. It's almost like the CA screening, and the treatment is almost like the same. Thank you. What? When I talked of moderate to severe colitis, that also included acute severe ulcerative colitis, and treatment of choice has been the corticosteroid. And once you achieve a remission with the steroids, then you can go back to azathioprine. But when you start giving steroids in such sick patients, you have to monitor therapy and you have to make your decisions on day 3 to day 5. If patient is not responding by day 3 or maximum by day 5, then you have to switch over, use other agents, salvage therapy. Like cyclosporine is a cheaper option. If infliximab is available, you can use. And though in Western world the JAK inhibitors is only used for those where the infliximab has failed, but this is one of the good therapy which can be used in such patients if he is not responding to IV steroids. And how do you decide whether patient is responding on day 3 or not? So you have parameters like C-reactive proteins. You have parameters like fecal calprotectin. If you have a baseline and if you see these parameters are coming down, it may not be normal, but suppose you had a patient of fecal calprotectin who had a measurement of 250, which has come down to 150, is still high, means he is responding to treatment. You can prolong the therapy for 5 days and see what is happening. Of course, you are monitoring the clinical signs and symptoms. If you see the clinically patient is improving, FCP is improving, CRP is improving, albumin is improving, or at least stable, then you know patient is making progress, you can continue with the therapy. But if these things are not happening by day 3 or day 5, don't linger on. Because what happens, if you linger on, the risk of colectomy increases in such patients and they will fail therapy. And it has been seen that if you have to use advanced therapy, use it early, then its response is better. Whether it is infliximab, whether it is cyclosporine, whether it is, and I would say even tofacitinib can be used because it's very fast acting. It has a very fast onset of action, so you can use it. Though in US it is only used in patients who have failed infliximab. So the effect is seen by 2 days only. By 2 days the patient would have had shown the effect, and it was quite effective. Almost in 60% of the patients, they responded, those who had failed biological therapy, responded to tofacitinib, and it is available with us. So we can use even that is one of the good options that we have.
Dr. Rakesh, nice talk here in the audience.
Yeah.
Sir, I have one comment and one query. First the comment regarding the latency in diagnosis. 9 months Western world, 2 year plus in our part. I think we have to make a difference between Crohn's and UC. Crohn's tends to be having larger latencies. As we see patient coming to us frequently, many years they keep on having bloating, small diarrhea, episode kind of thing. And UC they tend to be presenting a bit early. My query is, as per you, the agents that were used for induction has to be used for remission also. Then I think I am comfortable with maybe once we induce with the steroids, second, third remission we can go on that. In between, patient pass many years on mesalamine. What's your take on that? And number two, where you place budesonide in between as a remission therapy for particularly for use.
When you talk of remission in Crohn's disease, are you talking of Crohn's disease? Then when you have a patient of Crohn's disease who is mild, as per the criteria I mentioned, then you can treat him on SOS basis. That is one, or you can even just monitor him if he is asymptomatic in between. And what treatment do you use? People have used 5-ASA, but that has plus minus effects. Some studies have shown little better than placebo, some have shown as good as placebo. Steroids, short course of steroids or budesonide can be given in such patients, and then you keep them off any treatment. But in the category which is moderate to severe, age less than 30 years, who have disease beyond terminal ileum, and those who have perianal disease or extensive disease or have other associated conditions, in those patients, you have to use the steroid sparing strategy. You must have a steroid sparing strategy. Budesonide also for a long time will have the effects of steroid side effects. So in those conditions, you have to go to these agents. And of course, we do not have oral drugs available as yet, but if patients can afford infliximab, adalimumab, you can give, or even azathioprine. Once you have achieved a remission with steroids, you can keep patients on azathioprine if he belongs to moderate to severe group. Mild group, you can just treat one episode and leave it and just monitor, but keep monitoring by FCP, by CRP, or by endoscopy, whichever means, or by radiology, whichever means suits you, and keep monitoring such patients, and these patients will do well. Usually mild patients in Crohn's are those who have aphthous ulcer. You might be finding many times aphthous ulcers, and here minimal symptoms, minimal mild pain, which is disturbing to the patients, and they have only aphthous ulcers. You can treat them like this. But those who have extensive ulcerations and those, you have to upgrade your treatment. And like long-term budesonide for the maintenance therapy in ulcerative colitis is also not recommended. You have to, the basic premise of all this treatment is to get the patient off steroids, because steroid is, in a long term, has most of the side effects. That is why we have all these agents. Otherwise, employed the strategy of low dose steroids. Like many of the arthritis patients undergo, they are on the 10 mg of steroids or 20 mg, but you have so many problems coming up because of those things: osteoporosis, osteopenia, and all those things, diabetes, hypertension, and so many things. So that is why this is how it is to be treated.
So where you place JAK inhibitors in the induction as well as remission of ulcerative colitis at this point of time, should we use it at first line, second line after steroid, and any other thoughts?
Look, nobody has studied JAK inhibitors as a first-line therapy vis-a-vis steroids. Steroids is still the cornerstone of therapy, first-line therapy. And if it fails, in the Western world we have infliximab, we have upadacitinib, infliximab, vedolizumab, anti-IL-23 inhibitors, all those things are there. Ustekinumab, and even there, the JAK inhibitors has been placed after infliximab failure. But the reason the FDA did not give approval was because in arthritis patient they had shown that there was major adverse cardiovascular events and thromboembolism. But when the subgroup analysis was done, this was mainly in patients who were more than 60 years of age, who have been smokers, and who had other risk factors for these problems. And those who are below 60 years of age, or those even who are more than 60 years of age but non-smokers, these events were not seen. So practically you can use it. In India we have no other choice. Patients can't afford infliximab at times. So you have given steroids, by 3rd or 5th day you have decided it's not working, don't linger on with the steroids, switch on to tofacitinib. I think it's a very rational choice, and do not delay surgery in case if it is not working. Surgery is a good choice, and in fact, one of the Danish study, 15,000 patients they studied, Crohn's patient had undergone, for some reason they had undergone ileocolectomy of ileocecal region, and some of them had received infliximab for their disease, and they were followed. It was seen that after 5 years, those who had gone ileocolectomy had a better response. Though it was not done as a treatment of Crohn's disease, it was done because of stricture or some other problems, but they had done better than those who had received infliximab. So now people are thinking that in a localized Crohn's, ileocecal Crohn's, you can even offer, because every patient can't afford infliximab, you can even offer surgery as a primary treatment, and it has been seen that laparoscopic surgery is even better. So ileocecal resection, if one can do laparoscopically or even otherwise, is a good option for patients who can't afford infliximab.
Thank you. Many more questions?
When you stop,
as we are running short of time,
one question. Sir, when you stop azathioprine और ये adalimumab, patient कहता है सर अब तो blood नहीं आ रहा, दवा बंद कर दीजिए ना.
That is what I was telling, that earlier we used to think that symptomatic remission is good remission. Nowadays, endoscopic remission has to be there, and you take biopsy. If the biopsy shows that there is histologic remission, histology remission means what? What do we find in the disease? What happens when there is active disease? There are 3 things, which is basically neutrophilic infiltration, cryptitis, and crypt abscess. You have depletion of goblet cells, and you have basal plasma cytosis, increase in the plasma cells, and also crypt architecture distortions. What happens if the patient responds to treatment? The basal plasma cells should normalize, the goblet cells should normalize, basal plasma cells should come down, and the crypt architecture should get normal. Then you think that the patient is in the histologic remission, that is called deep remission. If a patient is in a sustained remission, clinical biochemical deep remission, for 6 to 12 months, 6 is for UC, 12 is for Crohn's, you can think of discontinuing therapy provided there are no risk factors. As I told you, patient doesn't have all those risk factors which I enumerated, like extensive disease and those things, who are more likely to develop complications. You can take them off and see how he behaves and monitor them, but not as a routine.
Okay.
Thank you.
Okay, Dr. Rakesh, for your wonderful presentation. And since it is a vast topic, lot of questions, lot of controversies are there, which can be discussed later on. Thank you very much.
Thank you so much, sir. Next, I request Dr. Rajiv Kumar Singh to please come on the stage to share on the topic AI of endoscopy.
Outside that, thanks to organizer to give them the chance to talk on the AI. AI is coming in a very big way. In 5 to 10 years, your practice will be changed by AI. Even today, patients are asking, doctor, you are going to perform colonoscopy on me. Do you have AI in your system? This is the scenario today. And those who have attended the Florida conference, they have seen that US has come with the AI. Automatically you will get the CVD, portal vein, pancreas, everything on the AI. And it is a game changer in US also. In colonoscopy, there is AI. and AI will tell where is the lesion, and you took biopsy from that lesion. The brief introduction, features and benefit, lower GI AI characterization, upper GI detection, and what literature says on the AI. As you know, AI has got the US FDA approval. Artificial got the US FDA approval. CADA is an innovative artificial intelligence solution from the widely recognized for its effectiveness in diagnosing the characterizing the colon and gastric cancer. It is extensively utilized worldwide for screening and diagnosing and treating the colonic and gastric lesions and polyps with many experts in the gastroenterology. Clinical studies has demonstrated that AI increases the adenoma detection rate, leading to enhanced early cancer detection by incorporating its technology for the clinician better detection, treat gastrointestinal disease promptly, thereby elevating the healthcare standards. AI in upper GI. What AI do in upper GI? There are 5-6 markers. When you see these markers, AI says that you have examined this area. So no area and no blind spots are left in the upper GI endoscopy. As you see LEJ, there is a green tick. As you see the greater curvature, there is a green tick. Lesser curvature, there is a green tick. So any area of the stomach is not left with the AI. Up to 6 millimeter of adenomas detected by AI. And the depressed lesion, it is very useful in diagnosing the depressed lesion. When you see the depressed lesion in the stomach, AI can give you the diagnosis, there is a lesion. And in the lower GI tract, there is a beep sound and visual assist circle is there. If you see any lesion, the circle will light up. So your mind goes, there is a lesion. Detection box is there. Detection box says, here is the lesion. Can easily toggle between the different modes with the help of a scope and simple operations. Then it can differentiate the lower GI. It is whether it is a hyperplastic polyp or neoplastic. If there is a visual assistance circle is green, it is a hyperplastic polyp. There is a box, there is a green light is coming and telling that it is a hyperplastic polyp. When you have a neoplastic polyp, yellow light blinks. Your mind goes that something is wrong. Here the yellow light is blinking and your visual assistance circuit displays in yellow, adenoma and cancer to be included. Your mind goes that there will be adenoma or any suspicious neoplastic lesion is there. The new CADA system used in LCI mode would process at least 60 frames per second, thereby allowing real-time video analysis sensitivity. Truly positive rate was 100% and no lesion will be missed. The 100% detection rate, no lesion can be missed, and calculated false positive frame rate was 1 on entire colon video was 0.001%. This is the beauty of AI. Among the 240 polyps, 34 were sessile-serrated lesions. Detection rate for sessile-serrated lesions with the CAD system used LCI mode was 100%. In this cartoon, you can see how the small polyp is detected, and there is a box is there to show that there is a polyp, and your mind goes there. Here is a polyp. You have to diagnose and treat the case. Again, literature says that adenoma detection rate with the white light is 20%, whereas the artificial intelligence is 30. So examination of adenoma in white light is 12, whereas in AI 18%. Examination with all advanced adenoma 2 and 4. Polyps 89 and 136. So you can see in this chart how AI is beneficial to detect the adenomas and polyps. In neoplastic lesion, adenoma detection rate with white light is 20%, whereas AI it is 30. Mean adenoma detection 0.3 and AJ 0.6%. So it is very higher detection rate with the adenomas and polyps and neoplasm. In this cartoon you can see the image of 3 mm flat adenoma, that is Paris classification 1LB with a high definition with a light endoscopy, artificial intelligence detection, linked color imaging, blue light imaging, differentiate the mode, and additionally image the advanced adenoma, Paris classification 2A, and high definition white light endoscopy. Here is a white light endoscopy, there is a LCI mode is there in this cartoon, and you can see the picture difference and the quality of diagnosis by the AI. Again, the ability of cat eye to detect polyps with white light and LCI. White light, they divided in this trainee and the experts. When trainee is doing with the white light, it is 78% only. When the expert is doing, it is 85%. With the cat eye, it is 96%, and with the expert, it is 99%, sir. And p-value, again, it is very high. The LCI with cat eye, 91%, when the expert is 92%. So p-value is again very high. White light imaging with LCI link color imaging is very nice for the detection of any polyps and disease. This is a picture that when first pass was there, we do the colonoscopy, no lesion was detected. We do the cat eye, there is some lesion and box is coming. When do the LCI shows that it is a neoplastic lesion. How early neoplastic lesion is detected, and by this detection you can do your therapies in early cancers in the colon. And again, AI is coming in the Barrett's esophagus also. It is a scope withdrawal time is also given by AI, that you are very fast in withdrawing, slow, you take 7 minutes or 8 minutes in the withdrawal, AI will tell. And again, the scope guide is also coming in AI. Where is your scope is in colon, it is guided by AI. Again, there is a polyp classification and polyp size can be given by the AI. So it is very easy for you to have an instrumentation for that polyp. Thank you, sir. Thank you.
Thank you, Dr. R.K. Singh, for your nice presentation on the upcoming AI.
Sir,
any questions from the
because
audience?
sir, AI can't differentiate ulcerative colitis and the inflammatory lesion. It will give the neoplastic lesion. This is your first question and I am answered you. Second question, sir.
I've got a few comments here to be made.
Yeah.
AI came into India way back in 2020. And AI has got two things, it is basically to be bought or kept. It is a passion and not a compulsion. It's a costly affair because the scopes are very costly. Both of us standing face to face have got it, so we know the difference of cost and everything. AI is too good for lower GI because most of the time we are not able to diagnose the adenomas which are being missed. And every adenoma is not cancerous and every adenoma is not benign. So vis-a-vis we need to basically find out whether you are having a tuberculous or the other things. Now two companies are there in the market, Olympus and Fuji. Fuji has got one big advantage that they are the pioneers. It all started from Japan. I have been trained under Dr. Yamamoto. The two things which are there, which are coming up, is the Japanese classification, the JNet, which is normally there. We are able to diagnose here, and in Fuji's system, we have got, as Saras showed very nicely, all the pictures.
that the characterization and detection are in the same module, whereas the other company has got two different things. You have got for detection separately, characterization separately, hence the cost matters a lot. In upper GI, sir, just to correct one thing, 6 major points as you said, there are 29 points which are ticked in the upper GI by the AI software, which shows that right from the lesser curvature to greater curvature to everything has been seen properly, and it keeps on getting ticked on the side of a screen in a PIP mode. Early detection of GI cancers, especially the early gastric cancer and esophageal cancer, has been really brought into action because of the upper AI which has come into action now. So you are able to treat the people by doing ESDs in a proper manner, that is the endoscopic submucosal dissections, which can give you a good treatment without asking the surgeon to intervene in between most of the times.
Thank you.
Sir, I have to catch a flight.
Oh, thank you, Dr. R.K. Singh, for your nice presentation and giving overview of AI.
Thank you so much, sir. Now I'd like to request Dr. V.M. Dayal sir to please come on the stage to share on the topic medical management of acute pancreatitis. Dr. V.M. Dayal sir.
Sir is leaving. I would request the chairperson to please felicitate.
Changes from this. Good morning. First of all, I must congratulate Dr. Manohar and his team for again putting up a grand show, although the attendance is a little less than desired. So from the heights of AI, we come to more mundane things, simple everyday topics, and I'm going to talk about acute pancreatitis. In a short span of 15 minutes, it's difficult to cover such a big topic. So I will only discuss some key concepts, and this talk is specially designed for postgraduates and physicians, general physicians in the audience. So I will go through these headings: introduction, diagnosis, etiology, severity assessment, and the management. So we all know the acute pancreatitis is an acute inflammatory process of the pancreas, and it can involve the pancreas and the regional tissues and even remote organs. So why do we talk about acute pancreatitis? First of all, it's a common problem, as you can see from the data. And second thing is, although 80% are mild and generally do well, in the 20% who don't do so well, we still are not really have any great options in terms of management or treatment. Though there have been some advances, but still we cannot say that we have conquered this last frontier. The mortality remains what it was 20 years ago. So in that way, it is an important topic to discuss. So how do we diagnose? With the typical pancreatic type pain, if the patient presents and has got either a high amylase or lipase more than 3 times upper limit of normal, or characteristic findings on ultrasound or CT, we make a diagnosis of acute pancreatitis. Normally, we would not do a CT or MRI at the outset. However, if the diagnosis is unclear or there is failure of improvement in the clinical situation,
or there are suspected complications, then the role of these imaging modalities comes. What is the etiology? There's a long list: metabolic, mechanical, vascular, infective. But overall, the most common cause is gallstone disease. Gallstone pancreatitis amounts to 40 to 70% of acute pancreatitis. Alcohol is the next big chunk. Post-ERCP, as the use of this procedure has expanded, so the complications have, and that also constitutes a good number of patients. After trauma and the idiopathic variety, which is one of the biggest chunks in which we don't find a diagnosis. Also, I would like to mention here that in older patients, say 40, 50 years or above, who present for the first time with acute pancreatitis and no other risk factors, one should also always be careful that there may be an underlying small tumor because of this. What should we test? Should we test amylase? Should we test lipase? Or should we test both? As you can see, we all know that amylase rises first and goes off early. Lipase rises a little later, peaks a little later, and then persists longer. Overall, it has been seen that if you use a combination, it is probably better, though cost is a factor. And once you make the diagnosis, there is no role actually of lipase level because it does not reflect the progression of the disease, it does not reflect resolution. So amylase lipase is most of the time is not required to be repeated, except when the patient has settled or has come back on follow-up and again with another attack, of course, then it becomes a fresh diagnosis. I'm showing these pictures for the classical signs: pancreatic inflammatory exudate causing bleeding, submucosal ecchymosis, gray tunnel size on the flanks, currents around the umbilicus, Fox's sign. On plain X-ray abdomen, you can get sometimes these classical signs like a small bowel. You get the central loop, the inflammatory exudates cause the spasm of the segment of the gut, and the unaffected segment is shown as a central loop or as a colon cutoff sign. On CT, you get the typical renal halo sign because the normal fat density around the kidney is disturbed by the inflammatory exudate. So you get the kind of halo around the kidney. Coming to the course of acute pancreatitis, basically it is now recognized that in most patients there are two distinct phases. The first phase, the early phase, and the late phase. And usually in the first phase, which lasts about a week, you may get SIRS or organ failure, and mostly in this phase there's less of infection. And those patients in this phase who do not have SIRS, organ failure, are usually the mild variety. And as I will talk in detail later, you don't need to give antibiotics in this phase. And unfortunately, I have seen even in our practice that the first thing that patient gets, apart from other, is dose of antibiotics, which is totally unnecessary. In the later phase, when there is some necrosis or there is some local complication and which can get affected, then you can get infection and you can get, you need antibiotics to treat. We know all know the classification. The initial in 1992 was mild and severe, but in 2012 was the revised Atlanta criteria. The mild is absence of local complications and absence of organ failure. Moderate is local complications with or without transient organ failure lasting less than 48 hours. And persistent organ failure with or without complications is severe. How do we diagnose organ failure? Basically, we look at three systems: respiratory system, renal system, and the cardiovascular system. And a score is scored from 0 to 4, as you can see in this chart. Any score in any system more than 2 constitutes organ failure. How do you assess severity? There are so many criteria. Ranson's criteria for alcoholic pancreatitis, revised Ranson score for gallstone pancreatitis, Glasgow-Emery criteria for acute pancreatitis, Apache 2 scoring system for acute pancreatitis. All these scoring systems are well known, well established, but mostly not usable because they are cumbersome. They take 48 hours most of the time to reach a diagnosis, to reach a conclusion about the severity. Useful index is BISAP, and in which the raise of 1, altered sensorium, presence of SIRS, age, and pleural effusion. And this can be done quickly. And if you get a score of more than 3 or more, that indicates severe disease. So you can see in this chart, most useful were BISAP and Apache. So in our practice, we like to use BISAP to stratify our patients. What is the role of imaging? You know that CCT is over 90% sensitive and specific. As I have already said, that we only use it after 48 to 72 hours because there is some evidence that if you use it too early, then it could aggravate the pancreatitis, especially the use of contrast, and to assess severity or local complications, other conditions. In this situation, MRI has some benefit over CT, especially if you're suspecting CVD stones, if you're suspecting PD disruptions or ruptures, and in fluid collections to assess necrosis, MR or US is better than CT. We all know of the Balthazar grading for severity of pancreatitis, but now we have got this modified CT severity index, which is simpler, and you can delineate similarly based on the morphological criteria, severity of pancreatitis. US is useful to detect CVD stones. It can be used to detect severity. Sometimes you can pick up a small mass in older patients. And in a series of idiopathic pancreatitis, it was superior to MRCP in diagnosing. Coming to the management part, we talk about pain relief, fluid resuscitation, nutrition, and antibiotics. Pain relief is very important. Patient has got severe pain, you have to give relief. And there is evidence to show that giving pain relief also reduces the stress and the inflammatory cytokines circulating. So overall, better for the resolution of the illness. We can use NSAIDs or opiates. We all know the complications. In one study from the AIMS, pentazocine was better than diclofenac in acute pancreatitis. And another study, tramadol, was similar to diclofenac. Normally we use tramadol or diclofenac or in combination with rescue with pentazocine. Fluid therapy, this is a very important aspect of the treatment of acute pancreatitis because adequate fluid resuscitation in the first 24 hours is critical for resolution of the illness and prevention of progression to more severe forms. And what do we aim to achieve? We aim to achieve an arterial BP of 65 to 85, a heart rate less than 120, hematocrit between 35 to 44, or a urine output 0.5 to 1 ml per kg per hour. And because there's a third phase loss, there's concentration, hypovolemia, and if you give adequate fluid in the first 24 hours, it's been shown to improve the prognosis for the patients. And if you miss this window, patients may come later, then fluid therapy is not so useful. ml per kg per hour. As you can see, there was no difference in the incidence of moderately severe or severe pancreatitis, but there was a significant amount of fluid overload in the aggressive group. So, based on this trial, it is no longer recommended to give very large amounts of fluid, but you have to give adequate amounts of fluid and monitor so that the patient is properly repleted and the injury is lessened. Which fluid to give? We can go normal saline or Ringer's lactate. Another study in only 40 patients. Lactate has been found in animal studies as well as in clinical studies that it reduces the systemic inflammation markers like CRP, reduces SIRS. So Ringer's lactate is the fluid of choice. And normal saline also may lead to hyperchloremic acidosis. Should we continue with the excessive fluid after 24 hours? One study compared the two groups with excessive high fluid volume and standard fluid volume, and there was no difference in the incidence of SIRS, of necrosis, organ failure, or the length of hospital stay. So overall, fluid restriction important the first 24 to 48 hours. After that, it is usual. So what is the recommendation? We should give 10 ml per kg bolus, and this can be repeated as per clinical situation, and then give a standard 1.5 ml per kg per hour. And those who do not have evidence of overt hypovolemia, you can straight away omit the bolus. Usually we give 3 to 4 liters in the first 24 hours. But when there's an elderly patient where there's evidence of cardiopulmonary disorders or there's renal failure, then one has to be cautious and monitor more carefully. How do we monitor? We look at the heart rate, we look at the urine output. You can follow the BUN and hematocrit. It is recommended that you do it at least every 6 hours to see whether it is coming down appropriately. You can do an ultrasound and look at the IVC diameter, or do a lung ultrasound if you are suspecting some fluid overload, or you can, if the patient is in ICU, if you have a catheter in place, you can look at the CPN map. Coming to antibiotics in AP, you can have several types of infections in acute pancreatitis, cholangitis, UTI, the infected fluid collections and acidosis, infected pancreatic necrosis. But as I discussed, in mild disease, most of the time, the antibiotics are not indicated, and they are also not indicated as a prophylaxis in patients with sterile necrosis. Only when you have evidence of infected necrosis or you have evidence of infection elsewhere in the body, then you can use antibiotics. If you're using antibiotics for necrosis, then you should use those antibiotics which are known to penetrate the pancreas and the necrosis, mostly carbapenems, quinolones, cephalosporins, or metronidazole. And there is no rule for routine use of antifungal agents in this situation. It's only when the patient is not responding very severely ill, then maybe you can consider. What about CT-guided FNA? Previously, it was the cornerstone that you get a patient with sterile necrosis who is deteriorating, first do a CT FNA to prove the evidence of infection. But now the emphasis is moving away from this method. Because if the patient with sterile necrosis deteriorates, you have to use antibiotics anyway, regardless of the results of the CT FNA. Again, if the patient is unstable, needing surgery, antibiotics will be used. And if there is evidence of positive blood cultures or infections at other sites, then you have to use antibiotics. So the role of this CT-guided FNA has diminished. Then coming to nutrition. Nutrition is also one of the cornerstones of the management of acute pancreatitis nowadays, because oral nutrition, especially enteral nutrition, is important because the maintenance of the gut barrier and the prevention of bacterial translocation, which is very important to prevent the complications. And it also has an effect on mortality. And most patients are able to tolerate oral feeding after a few days when the pain has lessened. So in mild acute pancreatitis, once the patient has got less pain and there's no nausea or vomiting, then you can start oral feeds. And first previously we used to give liquid feeds first, but now there's evidence to say that you can start with small solid feeds right from the first go. In severe acute pancreatitis as well, we should definitely ensure enteral nutrition as far as possible using a nasogastric or nasojejunal tube. Parenteral nutrition is only indicated when the enteral route is not available or not tolerated, or you are unable to meet the caloric requirements. So, obviously, in any patient of acute pancreatitis, the early course is important. At first, you have to make a diagnosis and then find out which is the patient falling in the mild group or the severe group. If it's a mild group, then you can treat in the usual wards. And again, the stipulations about fluid, about analgesics would apply. But if the patient is severe, it should be they should be managed straight away in the ICU, and once with the usual protocol, ICU protocol. If there's evidence of rising bilirubin or cholangitis, then there's a role of urgent ERCP, but most patients, ERCP is not required in acute pancreatitis. Later, when the mild patient, you continue the oral feeding, and generally in a week or 10 days, the patient can be released, discharged. In the severe patients, the patient continues the ICU, you start enteral feedings either orally or through NJ or nasogastric tube. In these patients, now is the time after 72 hours to do a CT or other cross-sectional imaging to look at the necrosis and other complications. And depending if there's patient continues to improve, then you can continue the same treatment. If there's evidence of nutrition and suspicion of infection, then role of antibiotics comes to play. So in the nutshell, I would like to say that in acute pancreatitis, it's important to make an early diagnosis. It's important to give adequate fluid right at the first. Use antibiotics appropriately, not in all patients. And focus on the nutrition. Early nutrition is critical. With this, we can hope to salvage most of our patients. And that is the message I wanted to give here to this audience. Thank you.
Thank you, Professor Dayal. Any question from the audience? I know it is a very interesting topic. Any question?
As alcohol and biliary, there are two variants of pancreatitis precipitating in, suppose in the setting of biliary pancreatitis, do we still persist with not giving antibiotics in early phase of pancreatitis as our primary line of treatment? Because we consider bile as an infected fluid.
Okay. So most of the time, by the time the patient has landed up to you, the stone may have already passed because it is said that there is a transient obstruction of the ampulla, blockage of the pancreatic duct, and that causes the pancreatitis. So unless the patient has got rising bilirubin, evidence of cholangitis, you don't need to intervene and you don't need to give antibiotics. It's only in the situation when you're suspecting that okay, the bile duct is still obstructed and infected, then you need to use antibiotics in this situation.
Dr. Dayal, yes, yeah.
Oh. Yeah.
Patient frequently comes with acute pancreatitis with paralytic ileus. Initial 4-5 days, no physis, no flatus. When you will start early oral therapy?
Okay, so this will be case to case. So basically, most of the patients who are mild pancreatitis, within 2 to 3 days, they are able to tolerate food, the bowels are moving. So you can safely start oral feeding. In those who have more severe disease, whose say gut paralysis persists longer, then you have to wait, you have to assess. But the aim should be to switch to oral intake as early as possible.
Just one question. We are seeing lots of cases of biliary pancreatitis. When you suggest that patient should go for surgery after an attack of acute pancreatitis?
Okay, very relevant question, and surgeon should take note. Actually, it is quite clear that if a patient with biliary pancreatitis has got mild disease, ideally we should have surgery in the same hospital admission. In the same setting before the patient gets discharged, he should have a cholecystectomy. But for so many reasons and reluctance, surgeons are strangely reluctant to operate on these patients, though it's quite safe. But if there's more severe disease, then of course, when the patient pancreatitis has resolved, that may take a month or a couple of months, then the window for cholecystectomy.
Yes, generally it is said that in the same sitting,
only for mild disease.
For mild disease, but in cases of severe disease, it is a bit confusing when to operate in those patients.
Usually, severe pancreatitis would, if the patient is in a fit condition to get discharged, would take 2 months, 1 to 2 months to settle. So I would think that after 2 months you can take up for surgery.
Thank you, Professor Dayal. Any questions?
One question. After recovering from the severe acute pancreatitis, is there any role of pancreatic enzymes, supplements? In the recent articles, initially we have read old articles that pancreatic enzyme replacement is not necessary for the acute severe pancreatitis when the patient recovers. But recent articles have come that if the patient has recovered from the severe acute pancreatitis, you may require pancreatic enzyme supplements. What is your idea?
Actually, if a patient has got a severe attack of pancreatitis, sometimes there is damage to the pancreas, the parenchyma is damaged, and the patient lands with chronic pancreatitis. So you have to make a clinical judgment whether you need to use pancreatic enzyme supplementation for that. The second situation would be if the patient is of chronic pancreatitis, having pain, use of pancreatic enzyme supplementation helps in the moderation of the pain. In that situation also you may want to use.
Good morning, sir. What is the indication of therapeutic ARCP within 72 hours? Patient having landing to gallstone pancreatitis.
So it's very clear, there were so many studies 20 years back of doing very early, within 72 hours ARCP, but none of them showed any benefit in terms of long-term outcomes or immediate outcomes. So, because most of the time it is only the small stones which migrate into the CBD, then block the ampulla, are supposed to be causing, one of the theories, cause pancreatitis. So most of the time, by the time patient has landed with pancreatitis, come to you, the stone may have already passed, and the jaundice, whatever was there, is settling. So there's no point in doing any intervention at this juncture. However, in the situation that the stone has lodged in the lower common bile duct, causing obstruction, cholangitis, then definitely you can go for ERCP and removal of the obstruction. In this case, it will be beneficial for the patient.
Thank you, Dr. Dayal, for your nice presentation. Thank you very much.
Thank you, sir. Thank you for the enlightening session. Before we begin our next session, I would request our chairpersons to felicitate our speakers, Dr. Rakesh Kumar sir and Dr. V.M. Dayal sir. I request our speakers to felicitate our chairpersons.
Now I request ML Prasad sir to please come and felicitate the chairpersons.
For the next session, I would now request our chairpersons, Dr. Professor Binde Kumar sir, HOD from the Department of Internal Medicine of RIMS Ranchi, Dr. Anand Singh sir, Dr. Deepak Singh sir, and Dr. Tej Narayan sir to kindly take the dais. I would also request our next speaker for the session, Dr. Saroj Kant Sinha sir, to come up on stage. Sir will be speaking on the topic Treatment of Ulcerative Colitis in 2025.
Good morning, everybody. And before I start, I would like to thank the local organizing committee for giving me the opportunity to be here and for excellent hospitality. So I'm going to next 20 minutes. I'm going to talk about the IBD part, not only ulcerative colitis. It's both ulcerative colitis and Crohn's disease. And so what we are going to see in 2025 and maybe a few years beyond. So for years what has happened that we have been treating more or less what I will say IBD as a symptomatic treatment, just controlling the symptoms, not bothering for any targets or not achieving any target point. So that era is clearly gone, and now what we talk is treat to target, and there is a stride to consensus, and we treat according to that. I'm not going to discuss a stride because of time reasons, and that is not the aim of the topic. And if you see 2022 guidelines, that it is heavily dominated by monoclonal antibodies, of which three commonly we use: infliximab, adalimumab, vedolizumab, and now lately istokimab. So these 4 drugs are currently in the mainstream, and for all difficult to treat patients, we try to depend on that. Lately, what we have is small molecules has become available in the form of tofacitinib. That is catching our fascination, and we are using more and more using that. But the limitation of tofacitinib that it is useful only in UC, not in Crohn's disease, and that is the main limiting factor in that certain situations. But lots of data have emerged in last few years, and what we are seeing actually the explosion which we few years back we witnessed with hepatitis C. We were inundated by the plethora of choices, and the same is going to we are seeing now in IBD. So I'm going to discuss about some of the molecules which we will launch in India in coming few years. And so you should be ready for the explosion, and because every new category of drugs lets you learn something new and how it should be used. Like conventionally, when we are using conventional medication, we were titrating the dose in milligram per day. But when you came to biological, we knew that this is not per day or per week dose you change. You change the dose by changing the interval of injection. Similarly, every new class, we have to see the nitty-gritty uses, indications, contraindications, and how to monitor those. So first I'm going to show you some of the drug choices and then how to make those choices. So if you see, there is plethora of choices and completely new class of drugs are emerging, and they are very shortly they are going to be launched. And top of the list you are seeing anti-adhesion molecules we have already in place, like vedolizumab is available, and but S1P modulators, ozanimod and etrasimod, they are not available but likely to become available shortly, and they are going to be in the mainstream. Then JAK inhibitors, tofacitinib we have, but shortly filgotinib we are at our center we are already using because we are part of the trial, but we are waiting for updacitinib to be available. Updacitinib is very important molecule simply for the fact because this is effective unlike tofacitinib in both in ulcerative colitis and Crohn's disease. So you don't have to bother much, and one can go for straight away for its use. So this is the difference in tofacitinib, which is pan-JAK inhibitor. In contrast, updacitinib is JAK1 inhibitor. So that is the molecule to be watched. Then we have ozanimod and etrasimod, which are S1P inhibitor or modulator, we should say. So these are the prime drugs. So then whenever you use the new drugs, particularly biologics, one should be very sure that you use according to the recommended dose, not at the whims and fancies that in your location, your patients require it in a lesser dose, because using in a lesser dose will invariably result in much lower efficacy. So that is the crucial point. And when you have to inject, because this is fixed dose ampoules, vials or infusions available, so if you want to change the dose, it is not the dose milligram you change the interval of administration of the drug. The drug. So here I have showed you ustekinumab, vedolizumab, mirikizumab and risankizumab. So all of them, vedolizumab is already available, usteki is already available in India, we are using. Risanki is also going to be available shortly. And then updacitinib, filgotinib we used in a trial. Ozanimod is also likely to become available. So one should remember these drugs. These are ozanimod and etrasimod. They are oral drugs, so that is the beauty that we will be more comfortable using that. So if you see risankizumab, this is IL-23 inhibitor basically. So if you see in Crohn's disease, this is efficacious compared to placebo, and then we have longer term effect for this, and in the form of recent 3 trial, and this was shown has good efficacy. Similarly, mirikizumab, which I told you that we also have first-hand experience. So in the symptomatic remission and stratified remission, we already have published data for 2 years, so it is efficacious. So that is already licensed for use. So, mirikizumab, this is for induction as well as maintenance. You understand that certain drugs are useful for induction, others are useful for maintenance. Like azathioprine, we don't use for induction, we use only for maintenance. So these drugs are mostly used both for induction as well as maintenance of remission, and mirikizumab was useful in both the situations. So that is the situation. Then vedolizumab you have seen, but in this field of monoclonal antibody, head-on trials are very few and far in between. So here I have showed you one trial which directly compared ustekinumab and vedolizumab. So vedolizumab, you know that integrin inhibitor and ustekinumab IL-12/23 inhibitor. So they were virtually comparable. So both can be used depending on the circumstances. Then we have S1P modulators. So S1P modulator, the first molecule was ozanimod, and then we have etrasimod. So this is the trial in ulcerative colitis. So this has been found efficacious, and this has been licensed for that. So this is the trial which is showing symptomatic response and remission. So fairly 70% is pretty high figure in the field of IBD, because so far you had most of our drugs going up to 50-55% efficacy rate only. So etrasimod is slightly better than possibly ozanimod, so that is also likely to come. So that also is a choice as of now. So we have intermediate and long-term results available for ulcerative colitis, so that also should be considered. You can see that clearly there is symptomatic response and remission rate. But you have to maintain, you will be disappointed to see that remission rate is reaching only up to 30%. So you will be disappointed. But most of these situations, these patients are difficult to treat IBD cases, and there the norm is less than 50% remission rate with any of the drug you use. So that is okay. So basically you have treatment options in the form of tofacitinib, ozanimod, upadacitinib, and these are the drugs which needs to be watched in coming days. Filgotinib is another one. So like here, obviously the choice is between the biologics and small molecules, because small molecules have the advantage of being oral, ease of administration, lower cost. So this is head-on comparison. This is one of the rare situations where direct comparison is available. So tofacitinib and upadacitinib virtually doing the same. So many of us will be inclined to use tofacitinib in India because of lesser cost, lower possibly lower adverse effect, and also ease of administration and better patient acceptance. So, I told you that because we don't have head-on comparison much of data, so when head-on comparison is not available, then we go for network analysis. So network analysis is the technique where you compare the data, all sorts of studies, and then you try to generate based on algorithm, a result which will give you gradation that what is the efficacy. So even if when there is no head-on comparison available, network analysis will be able to give you gradation. So all sorts of, this is the data which is available. So width of the line actually says you that how many data, how strong the data is available, risankizumab, ustekinumab, or what all sorts of comparison. And then you make an algorithm. So this is what it says, that overall still infliximab remains efficacious in naive patient. So bio-naive patients are still infliximab, and whenever you talk of infliximab, you always talk of use of infliximab with azathioprine, so immunomodulator. But when you talk of adalimumab, you talk of use of only adalimumab, it is not with immunomodulator. But in bio-exposed patient, you see risankizumab and upadacitinib, they come on the top. You ignore adalimumab because this is basically those patients who, because of adverse drug reaction related to drug, it came on the front. So the same is true in this also. This is also network meta-analysis. So basically these two drugs are on the. So that was for remission induction, and this is for significant response during maintenance therapy. So infliximab ranked highest and superior of all other drugs, but risankizumab and adalimumab demonstrating highest probability of early induction of remission, and upadacitinib and risankizumab induced highest clinical response in biological exposed patients. So in that situation, possibly upadacitinib. To my mind, upadacitinib is the drug to be watched in coming future. So in UC, again, this maintenance of remission, if you see data, then top of the here you see that upadacitinib is on the top of the list, and then tofacitinib. Tofacitinib we are already using, but when upadacitinib it will simplify, because in all sets of patients, irrespective of IBD diagnosis, it can be used. And again, you see gradation, and a gradation you will find that upadacitinib is pretty high second rank drug. So, so Janus kinase inhibitor and S1P inhibitor had its own set of concerns. Janus kinase inhibitor, particularly upadacitinib and tofacitinib, because of the risk of thromboembolism complication, it is not a preferred drug in the elderly patients, those with cardiac disease, those with the risk of thromboembolic complication, previous stroke, etc. S1P modulators are also some degree of cardiac toxicity, so this also needs to be used cautiously. So every drug will have some response, and that some limitation that I have listed here. So accordingly, one has to use it. Then now slowly the data is emerging on the use of combination therapy. Combination therapy, generally when we use combination of drugs from two different classes. Either say for TNF alpha blocker with small molecules, or two biologics of different class like infliximab with ustekinumab, that type of situation. And slowly we are seeing that in difficult to treat situation, combination drug has been used. But there is a limited experience, but more and more data is rapidly emerging, and I believe that what has happened in TB, what has happened in HIV, that we always go for combination therapy. So in future, all those difficult to treat IBD cases will be treated with combination therapy. So this is how you position therapies. So ulcerative colitis, ozanimod or etrasimod, that will be the good choice initially, and then other choices will be vedolizumab and ustekinumab. So this is how you position it, that if the safety first, meaning that CAD patients, stroke patients, then in Crohn's disease, the vedolizumab and ustekinumab remains on the front, and in ulcerative colitis, again the same drugs. And in other cases, the possibly tofacitinib and upadacitinib will come in the front in low risk cases, so that should be used. So I will summarize with the same. This algorithm is from one of the review article. So depending on age, sex, EIM, genetics, disease extent, nutrition comorbidity, and other comorbidity, cardiac, stroke, these are the choices: infliximab, adalimumab, upadacitinib, ustekinumab, and ozanimod. So any of these can be initiated, and if there is lack of response, then we will change the class, and according to changed class, we will be continuing therapy. Thank you all.
Thank you so much, sir. Next, I'd like to call Dr. Manoj Kumar Badani to come on the stage and share on the topic infectious hepatitis other than hepatotropic viruses. Next, I'd like to call Dr. Sanjeev Jha sir to come up on the stage to share on the topic endoscopic treatment on management of chronic pancreatitis. Dr. Sanjeev Jha sir.
At the outset, I would like to thank Dr. Manohar, Dr. Pranav and Dr. Jayanto for giving me opportunity for the presentation. And it's very difficult to present after Sarod sir and Dr. Rakesh. Dr. Rakesh was my teacher during my DM course. And so the topic of my presentation is endoscopic management of patients with chronic pancreatitis. As we all know, the chronic pancreatitis is the fibroinflammatory disorder of pancreas leading to the irreversible destruction of the pancreatic parenchyma and ductal system. It commonly manifested as a pain abdomen, which is the most common presentation of chronic pancreatitis, but it can also manifest as a exocrine and endocrine insufficiency or the complication related to the chronic pancreatitis. The pain abdomen is the most common presentation, and the chronic pancreatitis is widely prevalent with prevalence range from the 36 to 125 per lakhs population, and in India it is in fact the more prevalent seen in Indian population. The alcohol and idiopathic chronic pancreatitis are the two most common type of the chronic presentation. The pain in chronic pancreatitis is multifactorial, but the increased intraductal pressure due to the presence of the pancreatic duct stone or stricture is the most common and dominant factor causing the pain in patient with chronic pancreatitis. But in addition to pain, in addition to presence of the calculi and the stricture, the pain can also be because of the pseudocyst, biliary stricture, and the other local complications associated with chronic pancreatitis are presented as pancreatic fistula, the inflammatory head mass, and gastric outlet obstruction. In addition to local complication, the many systemic complications are also associated with chronic pancreatitis, like the diabetes mellitus, the steatorrhea, sarcopenia, metabolic bone disease, and the many vascular complications are also associated with chronic pancreatitis. So the role of endotherapy, the endotherapy is mainly indicated in symptomatic chronic pancreatitis patient with pancreatic ductal stone, the PD stricture, the bile duct stricture, the pseudocyst, pseudoaneurysm, and in some patient as a on short-term basis, we can give the celiac plexus block in chronic pancreatitis patient for temporary relief of the pain abdomen. So the pancreatic ductal stone, they seen in the 50% of at the time of presentation, but the frequency reaching up to the 100% after the 14 years of the follow-up. The main alcoholics, and the smoker are the main risk factor for the development of the pancreatic ductal stone. It can be classified on the basis of radio density, whether it is the radio opaque or the radio lucent, the location of a stone in the pancreas, whether it is in the pancreatic head, neck, body or the tail, or whether the stone is in single or the fewer in number or the multiple in numbers. So the techniques used in the pancreatic ductal stone clearance are the simple ERCP with sphincterotomy and the stone extraction, the ESWL, the intraductal lithotripsy by the EHL or the laser lithotripsy using the pancreaticoscopy, and the surgery. So the first come to the efficacy of sphincterotomy and the stone extraction. So the many study has shown in a special subset of the patient the complete stone clearance after the sphincterotomy and the stone extraction was seen in 60 to 70% of the patient, with almost similar proportion of the patient feel the clinical improvement. But those subset of the patient who were most benefited from the pancreatic ductal sphincterotomy and the stone extraction are the stone with a small size stone, the lesser number of the stone, more radiolucent stone, and located in the head and the proximal body. But those with larger stone, radio opaque, diffusely distributed, impacted or associated with the structure show the poor response to the simple sphincterotomy and the stone therapy. Now come to the study of efficacy of ESWL. So recently, a meta-analysis of 22 studies, including the more than 3,800 patients, of patients with chronic symptomatic pancreatitis with PD stone, they show the complete ductal clearance was seen in almost 70% of the patient, with patient free of pain during the follow-up was seen in about 2/3 of the patient, and the adverse effects are seen in almost 4% of the patient, with pancreatitis being the most common adverse effect seen with ESWL. So these are the several studies that showed the efficacy of ESWL in patient with chronic pancreatic duct stone. One study I would like to mention, done in the India by that Manu Tandon, that included the 636 patients, and they showed the pain, the ductal clearance in almost 77% of the patient, with 65% of the patient, the pain relief was seen in the 65% of the patient, though the data on the complication was not mentioned. And this study has done up to the follow-up study was done up to the 8 years. So even after 8 years, the pain-free, the 2/3 of the patient, they feel pain-free. So in addition to the ESWL, we have also the EHL and the laser lithotripsy. It can be used under the direct vision using the pancreaticoscope. In EHL, the bipolar the probe are used, which generates the 3 different shock waves to disintegrate the stone, whereas in laser lithotripsy, they uses the light of the different wavelength to produce the strong shock wave to disintegrate the stone. So regarding the safety and efficacy of the EHL and the laser lithotripsy, recently a retrospective multi-center study was done that conducted in the 17 center and included 109 patients with median follow-up of 210 days. They showed that complete ductal clearance in about the 90% of the patient, and of them the ductal clearance in one session was seen in the 73% of the patient. And almost similar proportion of the patient see the clinical success. And incomplete ductal clearance and the stone recurrence during the follow-up was seen in the 10% of the patient, and similar proportion also seen feel the adverse effect. The most of the adverse effect are the pancreatitis, the PD perforation, bleeding, fever, and the abdominal pain. So one more study that compared the efficacy of the ESW and the pancreaticoscopy guided lithotripsy, they showed the almost similar efficacy, but the lesser number of sessions in EHL and the LL group are required to disintegrate the stone. So as per the ESG guideline, they recommend the EHL or the laser lithotripsy is safer and efficacious, and it should be performed in the case of the failed ERCP or the ESW if the ESWL is not available. So the lithotripsy is not effective in all the homogeneous group of patients with chronic pancreatitis and the PDA stone. They are effective in special subset of the patient, and the ideal indication for the lithotripsy are the single or the fewer calculi in the head, genu or the proximal body, and stone should be more than 5 mm or the impacted stone. But it should be avoided if the stone is diffusely distributed or associated with the tight stricture, the suspicious pancreatic mass is there, or if the calcification is seen in the side branches or the parenchyma, then the lithotripsy is not shown to be very efficacious. So now come to the another feature associated with chronic pancreatitis is the pancreatic duct stricture. The way back in 2004, the pancreatic duct stricture was classically defined as the significant narrowing of the duct with upstream dilatation that prevent the flow of contrast besides a 6 French catheter. So to investigate the PD stricture, the MRCP and the CT should be done to assess the length and the location of the stricture, and the most importantly to rule out the malignancy. So these are the steps of the endoscopic management of the PD stricture. The first, the PD cannulation should be done, followed by the sphincterotomy, and then the dilatation of the stricture will be done by using the balloon or the boogie, and lastly the placement of the one or more plastic stent should be placed. So according to ESG guideline 2018, they recommended the placement of a single 10 French plastic stent for 1 uninterrupted year in patient with painful dominant pancreatic duct stricture if the symptoms improves after the initial successful ductal drainage. If the symptoms doesn't improve, then the multiple plastic duct or the fully covered stent may be placed, and a stent should be exchanged every 3 months or when the symptoms developed. So technical success in this scenario is defined as the complete runoff of contrast material or ability to pass the inflated extracted balloon through the stricture after stent removal. So to assess the effectiveness of the single plastic stent in the PD stricture, a study has meta-analysis has done that included the 16 study, the almost 1500 patients with mean follow-up of the 48 months. They show the immediate pain relief is seen in the 88% of the patient, and the long-term pain relief seen in the 2/3 of the patient, with complication rate of around 7.8%, with pancreatitis, stone occlusion, and the migration is the most common side adverse effect seen during this procedure. So even if the stricture doesn't improve even after 1 year placement of single plastic stent placement, then this type of stricture is called the refractory stricture. And the option, the endoscopic treatment option for in the patient with refractory stricture are the multiple plastic stent or the fully covered SEMS. So in 2004, a landmark study was published by the Magna Carta that included the 19 patients. They showed the multiple stent placement are effective in almost 84% of the patients even after the follow-up 38 month of the follow-up period. But the only drawback in putting the multiple plastic stent is the multiple session of the ERCP is required. So the fully covered SEMS is also effective to treat in patient with pancreatic duct stricture. It is mainly used in the proximal pancreatic duct stricture near the ampullary area, but the upstream pancreatic duct to be dilated up at least 5 mm for the placement of the metallic stent. The currently available stent are up to the 10 cm of length and with the 6 to 8 mm in diameter. So to study the efficacy of the fully covered stent in the management of the pancreatic duct stricture, a meta-analysis was published in 2020 that included the 10 study with 163 patients. They show the stricture resolution in 93% of the patient with stricture recurrence after stent removal was seen in the 5% of the patient. But one of the most important thing to note that the duration of stent placement more than 3 months is not beneficial. So if we decide to put the SEMS in patient with PD stricture, it should be removed at the end of 3 months. So another study was also published that compare the efficacy of multiple plastic stent versus the fully covered stent in refractory pancreatic ductal stricture. A meta-analysis was done that included the 13 study. They showed the almost similar effect as far as the pain improvement and recurrence after the recurrence of pain after the stent removal is concerned, but the adverse effect is markedly high in patient with fully covered SEMS group as compared to the multiple plastic stent group. But the subsequent RCT has also done that showed the adverse effect are also almost comparable in the both group. So surgery, as we all know, the surgery is also one of the option in patient to treat the pancreatic duct stricture or to treat the pain associated with chronic pancreatitis. So way back in 2007, an article published in NEJM that compared the efficacy of endoscopic versus surgical drainage in patient with chronic pancreatitis, and they showed the surgical drainage of pancreatic duct was more efficacious than the endoscopic treatment in patient with obstruction of the pancreatic duct due to the chronic pancreatitis. And in 2014 also, in 2024 also, a meta-analysis has done that included the 3 randomized control trial and 199 patients. They also showed the surgery is more efficacious than the endoscopic therapy in patient with chronic pancreatitis, and with crossover rate from endoscopy to surgery was seen in 22% of the patient. So where is the, despite this, these studies showed the more efficacy of the surgery as compared to the endoscopic therapy, the ESG is still recommended the endotherapy should be done in patient with chronic pancreatitis associated pain. So there are the spectrum of patients where the endoscopy therapy is more effective, and there are a spectrum where the surgery is more effective. So the endotherapy is more effective if the pain is of shorter duration of pain and patient is not on narcotic dependence, the single or the fewer structure are there, and the stone limited to the pancreatic head or neck with limited the fewer number of the stones. And the surgery is more effective in patient if the chronic pancreatitis is associated with some inflammatory mass or associated with multiple stricture or the significant stone. So after the ERCP and surgery, there is also a role of endoscopic therapy, the endoscopic ultrasound in management of the chronic pancreatitis. The US is mainly indicated in patients where the ERCP is failed or patient has an surgically altered anatomy where the ERCP could not be done, or in patient with tight stricture or a stone where the patient is not amenable to the ERCP guided technique. So there are two techniques for the US guided management of chronic pancreatitis, the rendezvous technique and the US guided antegrade drainage of the pancreatic duct. So to study the efficacy of the US guided drainage in chronic pancreatitis, a multi-center prospective study was done that included the 80 patients, and in this study the technical success was seen in the 89 patients. So the antegrade antegrade stent placement was done in 72% and the retrograde was done in 28% of the patient. The clinical success was seen in 80% of the patient, though the clinical success was more when the retrograde placement was done, and in antegrade placement the success rate was seen only in 76% of the patient. The adverse effect developed during the procedure are seen in 20% of the cases, where the bleeding pancreatitis, MPD leak, pancreatic fluid collection and the perforation are the main adverse effect. So the US guided pancreatic ductal intervention is safe and effective option in patients with pancreatic duct stricture where the ERCP failed or not possible. So in updated ESC guideline 21, they recommend the US guided PD drainage should only be considered in symptomatic patient with an obstructed pancreatic duct when the ERCP fails or not possible, and the rendezvous US technique should be favored over the transmural PD drainage owing to its lower rate of the adverse effect. So the other options are also available to treat the pancreatic duct stricture. They are the stricturoplasty. I am not going into details of this. And the other complication associated with chronic pancreatitis where the endotherapy is indicated are the benign biliary stricture. In patient with benign biliary stricture, the endotherapy is indicated when the symptoms of the CVD obstruction are there, or even in asymptomatic patient if the alkaline phosphatase raised for at least 1 month, then the endoscopic therapy is indicated in such a group. So in this therapy, the benign biliary stricture associated with chronic pancreatitis are usually resistant to the endotherapy, and the placement of single plastic stent showed the very suboptimal response. So the other treatment options are the placement of the multiple plastic stent or the fully covered stent. So to study the efficacy of the fully covered stent and multiple plastic stent, meta-analysis was done that showed the technical success, clinical, so the technical success are same in both group, but the clinical success and the clinical success are significantly higher in SAMES group, and the complication are significantly higher in multiple plastic stent group. So the fully covered SAMES is efficacious and more safer option than the multiple plastic stent for the patient with biliary stricture related to chronic pancreatitis. Now come to the endoscopic management of pseudocyst in chronic pancreatitis. Pseudocyst is seen in almost 20 to 40% of patients with chronic pancreatitis, with lesser number of patients as compared to acute pancreatitis, though they develop the spontaneous resolution, and the predictive factor of the persisting symptoms are seen in patients with intrapancreatic pseudocyst more than 4 cm or in patient with extrapancreatic pseudocyst. So the indication of drainage in patient with chronic pancreatitis associated pseudocyst are if the pancreatic pseudocyst causes the symptoms or develop the complication, or the pseudocyst lesser than 5 cm communicating with pancreatic duct, or even the asymptomatic and uncomplicated pancreatic cirrhosis of more than 5 centimeter diameter that do not resolve within the 6 weeks may be treated as a transmural drainage, but they are the weak recommendation. And the two techniques we should follow, the transpapillary and the transmural drainage. And there are the other indication for drainage also, even in absence of symptoms. They are the compression of the major vessels, the pancreaticopleural fistula, the pseudocyst wall more than 5 millimeter, and the pseudocyst associated with advanced MPT changes or the pancreaticolithiasis. So, this is my last slide. This is the algorithmic management of endotherapy in patient with chronic pancreatitis. So first, to assess the whether the pain is related to chronic pancreatitis or unrelated to chronic pancreatitis. If the pain is unrelated, then treat those conditions. If the pain is related to endotherapy, then first assess the whether the endotherapy is suitable or not, or whether the pancreatitis is associated with any mass lesion or not. If in mass lesion is there or patient is unsuitable to endotherapy, then patient should be directly referred for surgery. But in absence of these features, then we see the whether the patient has stricture, calculi, or the other extra pancreatic complication. In presence of stricture, we should first put the single plastic stent and see the response. If the patient is responded, then it's okay. Then if the patient doesn't respond to single plastic stent, then we should put either the multiple plastic stent or the fully covered stents. And even if the patient doesn't give response to this therapy, then the patient should be referred to surgery. In presence of the ductal calculi, if the calculi is small, then the ERCP and sphincterotomy should be done. If the stone is large or the impacted stone or associated with a stricture, then the ESWL or laser lithotripsy is the option. And in patient with extra pancreatic complication, then they should be managed accordingly. Thank you for patient listening.
Thank you, sir. And since we are running short of time, one or two questions can be allowed from the house if there is any question. So there is no question from the house, sir. I have one question, sir. If we want to start lithotripsy or ESWL in pancreatic duct stone, so who are the ideal candidates in whom there is good prognosis, in whom for a beginner I can try?
So I have already mentioned in my slide the patient with larger stone, impacted stone, and a stone should be fewer in number. A single or in presence of multiple stone, diffusely distributed stone, surgery should be the option.
Thank you, sir, for your well elaborated lecture. Thanks a lot. But I will request all the speakers kindly give respect to others' time also, because it is not a classroom, it is a seminar, and 12 minutes you cannot explain everything. So kindly stick to your time.
Next I'd like to call upon stage Dr. Manoj Kumar Bhadani sir to present on the topic infectious hepatitis other than hepatotropic viruses.
Good afternoon, everyone. Everyone is discussing about primary hepatitis, pancreatitis related disease, but I will discuss regarding hepatitis due to infection, that will be secondary. It may be due to bacterial infection, parasitic infection, viral or fungal infection. What is hepatitis? Everyone is knowing inflammation of liver characterized by various symptoms and clinical findings. This presentation will examine the roles of bacterial, parasitic, viral and fungal pathogen in causing hepatitis, emphasizing the importance of identifying a specific microbial causes is crucial for implementing effective treatment strategy and improving patient outcomes. What is role of liver in host defense? It filters blood from both portal and systemic circulation, playing a vital role in detoxification, also metabolizes nutrients and produces essential proteins including clotting factors. It has also role in immune defense. Houses approximately 1/3 of the body's reticuloendothelial system, which is integral in recognizing and clearing pathogens. It also produces immune factors such as cytokines and complement proteins, aiding in the immune response. Coming to summary of pathogen reviewed, it may be virus, bacteria and mycobacteria, parasites and fungi. Each and everything cannot be explained within short time. So in viruses, we have lot of cases about dengue virus and dengue fever. Again, in bacteria, there will be Salmonella and Mycobacterium tuberculosis are very, very common, and leptospirosis is also common. In parasitic, we are seeing Plasmodium virus, Plasmodium species malaria. It may be with Vivax or Falciparum. Coming to fungi, Candida and Histoplasma capsulatum. So there are a lot of bacteria can be grown it may be aerobes or anaerobes, and both are with gram negative and gram positive. So common bacterial causes are Leptospirosis species, causes leptospirosis, potentially leading to severe liver disease. Salmonella typhi, known for typhoid fever associated with liver inflammation when there will be secondary bacteremia. Coming to Mycobacterium tuberculosis, that can cause hepatic involvement in systemic tuberculosis, especially in disseminated tuberculosis. Brucella species, zoonotic species infection leading to mild hepatitis. Coxiella burnetii causes Q fever, which may affect liver function. All these bacteria may directly invade liver cells and disrupt cellular function and induce inflammatory response that lead to liver disease. So coming to leptospirosis, it is caused by Leptospira species and primarily transmitted to humans through contact or water, soil or food contaminated with urine of infected animals. Patient may present with fever, jaundice and liver dysfunction, with severe cases developing Weil's disease characterized by hepatic failure. It can be diagnosed with blood test and serological assays for antibodies. Antibiotics such as doxycycline or penicillin with supportive care for severe cases. This is the leptospirosis, how there is transmitted from rat to animal, animal to human being. Coming to typhoid fever, this is caused by Salmonella enterica serotype typhi. It is transmitted through fecal-oral route via contaminated food or water, and asymptomatic carrier is also responsible for infection spread. Patient may present with high fever, does not subside and does not touch basal line. There will be relative bradycardia, elevated liver enzyme, jaundice or systemic symptom like high fever and abdominal pain. It can be diagnosed by blood culture, liver function test and stool culture. Fluoroquinolones such as ciprofloxacin and are the treatment. Vaccines for the prevention may needed. This is how diseases are transmitted in Salmonella typhi.
Coming to tuberculosis, miliary tuberculosis can spread to the liver, resulting in glomerular hepatitis. Patient may experience fever, weight loss, abdominal pain, and hepatomegaly. And diagnosis can be done by imaging studies, liver biopsy revealing gliomas, and culture of liver tissue. Treatment will be as usual with 4-drug regime. Coming to brucellosis, it is caused by Brucella species. It is primarily zoonotic. Transmission through direct contact or infected animals or consumption of contaminated dairy products can cause hepatomegaly, mild hepatitis, along with systemic symptoms like fever and night sweats, and it can be diagnosed with serological assays and blood culture to confirm the infection. A combination of doxycycline and rifampicin over several weeks is for effective resolution is required. Q fever, it is uncommon in our country and presented with mild hepatitis, often accompanied by flu-like syndrome, a flu-like symptom, and granulomatous lesion in the liver. Serological test for phase 1 and phase 2 antigen and PCR assays. Doxycycline is the first line of treatment for acute infection. So these are the bacterial hepatitis are very common, caused by Leptospira, Salmonella, Mycobacterium, Brucella, Coxiella, and we have to emphasize on the diagnosis and treatment to prevent the liver involvement or other complication. Coming to parasites, there are a lot of parasites infective. In fact, there is infection of liver. It may be Ascariasis, Babesiosis, Cryptosporidiosis, Echinococcosis, Entamoeba histolytica, Plasmodium species. But very few are very common in our state, in our country. That is the malaria, and it may be due to Plasmodium vivax or falciparum. So, Entamoeba histolytica causes amoebic liver abscess. We usually see regularly on OPD as well as IPD. Schistosoma species associated with chronic infection leading to liver fibrosis. Echinococcus species that causes hydrated cyst in liver and other organs. What is the mechanism of damage? Parasites can lead to liver damage through abscess formation, fibrosis, or granulomatous infection. Coming to amoebic liver abscess, it can be caused by Entamoeba histolytica with symptom will be fever, right upper quadrant pain, jaundice, and in severe cases there will be hepatomegaly. It can be diagnosed by very high total count with raised bilirubin and liver enzymes, and we can diagnose with ultrasound imaging to identify the abscess and serology for antibody. Metronidazole and tinidazole are opt for best treatment, followed by luminal agents like idoquinoline, and surgical requirement may be needed sometime. Schistosomiasis, it is a chronic infection, may lead to portal hypertension, abdominal pain, hepatomegaly, eventually resulting in fibrosis and cirrhosis of liver. It can be also diagnosed with serological test, stool examination of ova, and imaging studies. Praziquantal is the drug of choice. It can be continued for few weeks. This is the life cycle of Schistoma species. And coming to Echinococcosis can be caused by Echinococcus species, often asymptomatic until complication arise, such as hydrated cyst in the liver leading to abdominal pain. Rupture of cyst can cause severe allergic reaction and anaphylaxis. Imaging studies to visualize the cyst. Surgical removal of cyst or medical management with albendazole can be done. This is the life cycle of Echinococcus granulosus. Coming to Plasmodium species, this is malaria-related hepatitis. Plasmodium species which are common in our state, that is the Plasmodium vivax and falciparum. but Plasmodium falciparum is responsible for hepatic dysfunction, that is indirect hyperbilirubinemia. It can be diagnosed with abdominal pain, fever, fatigue, renal failure, in rare cases hepatic encephalopathy. Sometimes hepatocyte necrosis, cholestasis and glomerular lesion with malarial nodules. And there will be present, especially in Plasmodium falciparum, renal failure, ARDS and septicemia may happen, and mortality rate up to 40%. And on investigation, elevated bilirubin liver enzyme to detect Plasmodium parasites in blood smear and glomerular lesion and hepatocytes necrosis in histology. Hepatosplenomegaly is very common, and jaundice more common in P. falciparum malaria. There are few fungal hepatitis. It can be Candida species, Histoplasma, Capsulatum and Aspergillus. We are getting more patients with Candida and Aspergillus. Candida has choice of treatment with liposomal and amphotericin B followed by maintenance therapy with fluconazole, and Histoplasma capsulatum is confirmed by liver biopsy, and itraconazole filed mild to moderate infection and amphotericin B for severe cases. Same thing Aspergillus. Coming to most common thing is there is a viral infection, herpes simplex virus can be treated with acyclovir and is preferred treatment. Liver transplantation may be necessary in severe cases. Yellow fever, this is very uncommon. And coming to dengue fever, that will be last, and it is spreaded by Aedes mosquito leading to outbreak in tropical region. This will be presented with severe headache, retroorbital pain, abdominal pain, elevated liver enzyme. Severe cases can lead to fulminant hepatic failure. Clinical evaluation, serological test, PCR. There will be severe thrombocytopenia where maybe blood platelet transfusion may be required. So it should be diagnosed as early as possible, and to know the complication of especially dengue, which is very prominent and dominant in our state, in our Ranchi also. So now coming to conclusion, hepatitis can arise from various infectious causes, each requiring a specific diagnostic and treatment approach. Early identification and appropriate management of underlying infectious etiology are crucial for improving liver health. So, thank you.
Thank you, sir, for your elaborate. One or two questions can be taken from audience if you have any questions. Thanks a lot, sir. Sir, I have one question. What are the adult vaccines that are recommended to prevent not only hepatotropic viruses, but overall any adult should take to prevent other respiratory viruses and in general for general population?
For entry fever, there is a typhoral, and all are due to other hepatitis virus. For that is the for hepatitis B, and other are not so common.
Thank you, sir. Thanks a lot, sir.
Thank you, sir. Next, I'd like to call Dr. Saurabh Jaiswal, sir, on stage to talk on topic update on cirrhotic cardiomyopathy. Dr. Saurabh Jaiswal, sir.
Good afternoon, everyone. Thank you for the organizers for inviting me here, especially Dr. Ravish. So the topic is some update on cirrhotic cardiomyopathy, CCM in short. So this is one topic we all have written a short note or a long question in our PG days, but I doubt that anybody practicing here in his OPD prescription has written the diagnosis DCLD, portal hypertension, and case of CCM. So I'll just try to put some light on this. So interaction between heart and liver, it goes both ways. If the heart is the primary disease where it is occurring and liver gets secondarily involved, that we know as cardiac cirrhosis. While if the liver is the primary disease and later on heart is getting involved, that leads to a condition, cirrhotic cardiomyopathy, which is today's discussion. And there are some conditions which affect both in parallel, like alcohol. It can cause alcoholic cardiomyopathy and alcohol-related liver disease. So we will be discussing on the second topic. So in a CLD's lifetime, many guests come knocking at his door, and we all identify as patients, as doctors. It may be ascites, GI bleed, AKI, encephalopathy, and we put it down in our prescription and discharge summaries. But CCM is a guest, somehow invisible to us. And it's not that it's very rare or uncommon thing. It's the prevalence is 30 to 60%. But I would just like to have a raise of hand. Anybody who has written this diagnosis in his discharge summary over last 6 months in his OPD? I think nobody. We write everything, the other things which we have discussed as the diagnosis, as the finding, but somehow we missed the cardiomyopathy. So why so? We'll try to have some clarity. The historic perspective, it was identified almost 70 years back. The term was coined in 1996. We had the World Congress of Gastro-Criteria in 2005, which we used for last 20 years. And recently in 2020, we have the CCM Consortium new guideline, which we'll be discussing. So what is the definition? A very simple definition. Any cirrhotic patient has systolic dysfunction, that is abnormal contractile response to stress, plus minus diastolic dysfunction. In the absence of any other significant cardiac disease, this is known as CCM. And its prevalence is around 30 to 70%, depending on various series which is studied. From India, there was the last single center experience published in 2019. They studied around 5,000 odd patients, around 600 had complete cardiac evaluation done, and the prevalence was around 34%. Males, it was more common in males, and the important thing, it was independent of the etiology of cirrhosis, and it was independent of the severity of cirrhosis. So with that background, what is the pathophysiology, why it occurs? So this is the proof of concept animal model. What they did, they had a bile duct ligation of a mouse liver. So what it will lead to hepatic inflammation and fibrosis, mimicking a cirrhosis condition. And within a few weeks, it was seen that in the heart, there was myocardial and vascular inflammation, systolic dysfunction, diastolic dysfunction. So this proves that indeed cirrhosis can cause cardiac disease. So this is the pathophysiology, like the structural part, cirrhosis, and the vascular hyperdynamic part. Both of them involve heart in some way or other. In short, in cirrhosis, there is abnormal lipid phosphorylation, we all know, leading to change in membrane fluidity of cardiomyocyte, which leads to diastolic dysfunction. And the hyperdynamic circulation, the leaky gut, the endotoxemia, the inflammatory milieu, they also lead to the systolic dysfunction. So it is in the center lies the hyperdynamic circulation due to the portal hypertension, which leads to myocardial inflammation, myocardial fibrosis, subendocardial edema, and CCM occurs. So what are the clinical effects? So it's often asymptomatic. That's why we miss it in our OPDs. The clinical features of any heart failure, fluid retention, dyspnea, reduced exercise capacity, are the same symptoms which occur in every cirrhotic. So that's why it remains masked. And when it gets unmasked, in periods of stress, such as overlying sepsis, surgery, any critical illness, post-TIPS and post-liver transplant, it gets unmasked. So why it is hidden from sight? In short, due to the cirrhosis, leaky gut, endotoxemia, as we discussed, This leads to systolic and diastolic dysfunction, but the splanchnic vasodilation leads to hyperdynamic circulation, because now there is very increase in preload, more blood is coming back to liver, to the heart, and there is decrease in the afterload. So the diseased heart is able to pump enough. So ejection fraction is maintained. Therefore, cardiac output is maintained, and therefore this is hidden from sight. So where we should look in the natural history of a cirrhotic, where we should look for CCM? So never in the compensated cirrhosis. It always occurs in the decompensated and the late end stage liver disease. If we are diagnosing CCM in compensated cirrhosis, our diagnosis should be wrong. So it occurs in the decompensated phase and late when the patient is waiting for transplant. So what are the diagnostic criteria? It's a diagnostic challenge, as we already discussed. So 2005 criteria we were using as per the Montreal World Congress, which gave this criteria. Very simple criteria. In the absence of any known relevant cardiac disease, if there was systolic dysfunction defined as LVEF less than 55% and decreased contractility with stress done by stress echo. Diastolic dysfunction, E by A ratio less than 1, and some supporting criteria. Will not go into the details. But what is the problem with 2005 criteria? LVEF less than 55 is a very high cutoff, so many patients were missed. E by A ratio, what is that? Just in short, you can see from this chart, we know that there is, when the heart relaxes in diastole, there is an early filling, and then late there is atrial contraction, and then there is late filling. So E is always more than A. So E by A ratio is more than 1 in a normal person. When diastolic dysfunction occurs, as you can see the second grade 1, E becomes less than A. But the thing is, as you go to grade 2 and grade 3, E becomes again more than A. So if you just have an E by A less than 1, you will miss grade 2 and grade 3 diastolic dysfunction. So in simple hands, a technician doing an echo or somebody who is not sensitized to this, they will miss the diastolic dysfunction. So this was the limitation. Then IVRT more than 80 millisecond, again, as the diastolic dysfunction progresses, it again shortens because it is a U-shaped curve. So again, we will miss that. Stress echo, as per the criteria, even a normal cirrhotic person who is decompensated, even without CCM, if you ask him to undergo a stress test, it can come as false positive. So there were many problems with 2005 criteria. So this cirrhotic cardiomyopathy consortium was formed. Multiple meetings were held from 2018 to 2020 with 3 groups: hepatologists, cardiologists, and anesthetists, because they deal with these patients. And it came up with the refined criteria published in 2019. And what they did, the fine tuning of echo is the important. It involves tissue Doppler, speckle tracking, global longitudinal strain, and left ventricular volume index. So basically everything depends on a good quality echo. So as you can see, this heart diagram, apart from assessing the flow into the ventricle, the mitral leaflet velocity is assessed. So as the diastole dysfunction occurs, the velocity of the mitral leaflets becomes slow. So in the lower part where the arrows are there, though E by A ratio becomes again normal in grade 3 and 4, but you can see that the E prime, the leaflet velocity is labeled as E prime. So E prime gradually gets smaller, the velocity gets low as the diastolic dysfunction progresses. So when we divide E by E prime, it's always a positive number. So increasing E by E prime is one of the important criteria of the new guideline. The second is global longitudinal strain. It is very simple thing, how much the myocardial contracts with the systole. So you have to, it is more than 18% contraction is normal, anything less than 18% is abnormal. And this is a bullseye plot. You have to ask your cardiologist to give this report in his echo, only then you can diagnose. It is a simple 17 segment representation of the heart. The periphery is the periphery of the left ventricle, in the middle is the basal part, then in the center is the apical part, and the red is normal. It is labeled in a colored way. Like if it is in the red, suppose in the first chart is showing normal global longitudinal strain, the second is showing that the apex is good, but the peripheral there is myocardial infarction and the peripheral part of the heart is not contracting. So with this chart, anything less than 18 is abnormal. So CCM 2020 criteria it was revised. LV ejection fraction was taken now as less than 50%. The longitudinal strain less than 18%. Septal E prime less than 7 speed, and E by E prime is more than 15. So these are the basic criteria which changed from 2005. There are potential other markers, will skip those things, the ECG markers, prolonged QTC interval and all. These are just for the detail. So how common is the newly defined criteria now? So various studies now show that when we use the new criteria, the prevalence is around 27%. Here, just a few slides. So can the old criteria still be used? So this study did a retrospective study, around 210 patients waiting for liver transplant. So with old criteria, the prevalence of CCM was 77%. With new criteria, prevalence is only 30%. And with old criteria, the hazard ratio was insignificant to predict major adverse cardiac event, while the new criteria, the hazard ratio is 2 and very significant to predict the adverse event. What are the clinical implications now? Basically 3. What to do with a patient of DCLD who has now CCM, how to manage TIPS, and how to manage liver transplant. So very much in short, in any patient of DCLD, we all put the patient on beta blocker. So various studies came once the refractory ascites developed, whether to give beta blocker or not to give beta blocker. So some studies showed harmful effect, some showed neutral effect, some showed beneficial effect. So we are in confusion whether to use beta blocker, not to use beta blocker. So this is a study which elegantly studied the cardiac output and CCM with use of beta blocker. So the above chart, if the cardiac output is less than 5 milliliter per minute, it showed much enhanced mortality, while those on non-selective beta blocker, while those who had enough cardiac output had low mortality. So we can use CCM as the criteria to decide whether we should use non-selective beta blocker or not use it. So again, this is done by cardiologists because all the cardiac failure patient, hypertension patient are on metoprolol. So they studied whether metoprolol can be given or not. So when they studied metoprolol, it was not effective. Now second part is TIPS. So once we put a TIPS, the preload increases. More and more blood is going to the heart. Already there is CCM, so the heart will fail very fast if we have not assessed for it. So as we see, the cardiac output increases after TIPS by 30 to 34%, and other parameters all increase. So it is seen in short that post TIPS, if we have not assessed for cardiac cirrhotic cardiomyopathy, then up to 20% cardiac decompensation can occur in post-TIPS in 1 year. So this is one important take-home message. So the recommendation is to do echo follow-up every 3 months post-TIPS. Regarding transplant, coming in short, if we are not assessing for CCM as it is masked, so we see that it is the first cause of early post-liver transplant death. And it is third most common cause of late post-liver transplant death. And doing a liver transplant is a landmark thing for the patient and for the hospital and even for the state. So if you miss a CCM case, it will land up in complications over the coming year. So which marker predicts the MACE prediction? So E prime, as I told, E prime is less than 7 is the highest. It predicts the MACE. Now coming last slide for the treatment part. So targeted heart reduction is one thing which is shown to be quite useful. Like if we use beta blockers to reduce the heart rate by 5 beats per minute, there is 14% risk reduction in the mortality. Second part, spironolactone becomes the drug diuretic of choice because it blocks the aldosterone axis, RAS axis, which is very active. Beta blocker, we should stop metoprolol. We can use carvedilol while the window remains open. AC inhibitors have to be avoided. ARBs can be used. Ivabradine can be used. There is some role of UDCA and OCA. Ciprofloxacin or any antibiotic to decrease the endotoxemia. Albumin, taurine are found very helpful in various trials, and liver transplant is the definite treatment which cures the condition. So I'll end the talk with the take-home message that we should suspect it in every ESLD patient. We have to get a good quality echo done, only then we can diagnose it. Always consider in pre-TIPS and pre-liver transplant workup. Involve cardiologists in care, and we have to optimize the medications. Thank you.
Thank you, Dr. Saurabh. Now the topic is open to the House for discussion. Mike.
prevalence rate was around 70%, and most of the abnormality was because of diastolic dysfunction. ठीक है ना? तो I want to know what's the prognostic significance of GLS per se, and the diastolic dysfunction criteria was based on 4 features, I think. E prime velocity, E by A, and left ventricular volume index, and the tricuspid regurgitation volume. So suppose if only one features are there, then how confidently you diagnose a case of cirrhotic cardiomyopathy, and is there any other parameters you would like to apply, like the IVRT and the A by A?
Yeah, definitely, sir. This was a very short just presentation to give the overview. The CCM 2020 criteria, they have listed a detailed guideline, like any one of the systolic parameters, which include multiple parameters, any 3 or more of the diastolic parameters, and then there are supportive parameters also, which include ECG, which includes stress test. So it is not that all have to be present. Any one is present from the systolic, any 3 from the diastolic, from the multiple criteria, all we can diagnose with that. And most sensitive is E prime and E by E prime ratio. Stress test they have removed from the picture because to do stress test in an end-stage liver disease patient is problematic, and it comes as a false positive also sometimes. So that is stress echo has been removed from the diagnostic workup.
In our day-to-day clinical practice, in a DCLD patient, what are the investigations, cardiac point of view, that we should know?
Yeah, see, so when to suspect it, when it DCLD patient, we see that we are optimizing the medications, but somehow is not responding to the diuretic dose. He is worsening. Otherwise, liver function, you see that it's not worsened that much, but somehow the patient is not responding. That time we should have our antennas high that it may be something else rather than only liver. So if we suspect it, we will ask for it. And how to ask for it? To get a echo done, asking that please label on the GLS, please write on LAVI, please write on E by E prime, because basic echo it just contains E by A ratio. They don't mention any of the parameters which we discussed. So if we ask for it, we'll get the answers.
Thank you, sir.
Thank you. Thank you.
Thank you, sir. For the next session, I would like to call on stage our next speaker, Dr. Ashok Chaudhary, sir. He will be speaking on the topic acute on chronic liver failure management before liver transplant.
Good afternoon, everybody. At the outset, thanks everyone. So I think we'll go for a little bit of difficult yet boring areas, I can say. I will try to make it interesting if possible on your side. So I think SLF is a definition. I'm not going to waste time. Everybody knows this, but just this is the definition. Now we can think of having a liver disease with hepatic or extrahepatic organ failures, and they have a very high mortality. And once they get admitted, they develop an insult, then they progress. And this is defined as the organ failures. You can see the curve is sharply rising up as the number of organ failures are going on. So what are the challenges faced in this group of patients? You can see the management concern is mainly this 3-pronged approach without transplant, that is need a general care. We need the disease-specific therapies, and now coming up some emerging therapies, and the rest are the experimental. So just to communicate, we need first to address complications because this is the first step towards recovery. The goal is optimization. As discussed, it is a bridge to the transplant. If you think of any complications, if a person is having So first of all, the cirrhosis is there, the mortality is on the higher side, you can see here, and is significant. If no cirrhosis, there may be having good scope. So either presence of significant ascites or renal failure, HE, infection or bleed, anything can cause highly soaked mortality. So this is the first concern you have to think of. So this is data from the ARC. You can see the bleeding itself increases the mortality by nearly double, nearly 1.9 times the mortality is increased. And there is a rapid progression in the varices. You can see the patient may not have varices. They develop acute portal hypertension, or they have small, this rapidly shoots to become a large, and this is associated with all these parameters of having worsening of ascites, bleed, and also indirectly related to other complications. And carvedilol, mostly these patients few tolerate, otherwise beta blockers has a little bit shown to have a better survival. The next comes the hepatic encephalopathy. Any person comes to you with SLF as a diagnosis. If there is no hepatic encephalopathy, chances may be better. But if it is grade 1 to 2 or grade 3, 4, then mortality will become significantly, drastically, rapidly down at baseline or any point of disease. So any patient with SLF, if you found that hepatic encephalopathy, then you have to think of. And then simply ammonia itself also, in absence of hepatic encephalopathy or irrespective, says on one of the predictors that it is going to pour out. The next important is the AKI. You can say kidney is the second most organ after the liver to be affected, and it is nearly 1/3 that should have a AKI. And most important that AKI, they have a structural damage. If a patient have a SLF, the AKI has started, the story starts now going down, and it is different than the decompensated cirrhosis to have this completion, and they requires low resolution, high recurrent renal replacement therapy is required. You can see here, if a person is having stage 3, and male bilirubin is more than 22 or R score is more than 10, they are likely to have a develop a rapid progression of AKI, which is to be stage 3. And if more than 35 itself tells that your patient is going to have a likely chance of a dialysis. So that is how, even in absence of A, you can get little bit clue for this patient to have an advanced AKI which may require dialysis. Once a SLF patient starts dialysis, it becomes very difficult. Then how to treat? So now it shows that terlipressin is little better than the Norelin for these patients, and they show some recovery. But you can see that they have a little bit of side effects also because of the high bilirubin and also high AKI, close to 15%. Most commonly it is the diarrhea, and sometimes you may take hand and foot gangrene. So whenever giving SCLF or any CLD patients of terlipressin, always try to examine his extremities. It becomes cool, then becomes cyanosis. That's a very early sign to think of. So then we thought of the standard guideline for is that you consider terlipressin to be started after 24 hours of optimization. Because now things that SLA patients already in hospital with you, don't wait for 24 hours. You can start terlipressin at 12 hours, and it shows a better results than those being given after 12 hours or after 24 hours. Then next comes the infection. I think everyone, the common practice is we don't have any infections, but we don't want to take chance. We provide antibiotics to every patient of SLA but admitted. And you can see this is to some extent you cannot be refuted or can justify, but a patient of SLF you can get the infections tune. Most common is SVP, UTI and chest infections, and also other infections coming up. And this is very crucial period, the golden window. Once you get admitted, no infections, around 65% have shots, and around 1/3 of the patients will develop sepsis in a period of first weeks. And that is story where the patient starts downfall because of this. Hence, antibiotic prophylaxis, though evidence is not robust, we need to give, and that depends upon the site of investigation. So these are the common practice of antibiotics. I don't want to go in deep. However, if you have to take the history in terms of local epidemiology of infections, site of infections, individual patient, what are the risk factors, clinical severity and infection source to decide the antibiotics. And most important there, now the fungal infections with the steroids, prolonged hospital stay is coming up, and also gram-positive are covering up. So any patient after being hospitalized, if any deterioration beyond 1 week, you should consider escalating antibiotics as well as to add on antifungals. And these are the factors which also took into mind because this patient likely to go for the transplant in future. So we have to think of the hospital pattern before giving a broad spectrum to prevent the MDR organisms. So these are rough antibiotics protocol, I don't want to go for detail because it is variable for others. Most important that if infection is there, that is not the story ends there. Infection can be optimized, they can go for the transplant in future to have a good outcome. So only thing that if they have a pre-transplant infections, they must have a prolonged stay. Then next important to cross is we need more data, but I think empirical and narrow spectrum as per local should be considered, and I have not covered the area of biomarkers, particularly procalcitonin, presepsin and hepcidin are coming up. Then next important what challenges we see is the coagulopathy. So these patients when they come, we have to think of their coagulation, how to assess will cover, we have need to stratify them, then we have to see what therapy we are giving and how we are monitoring. So these are the parameters you know, but none is adequate to predict a bleed. Neither platelet, and should not chase the platelets. INR we cannot correct if the whole blood bank will become empty with plus supplementations. And procoagulant factors are difficult to get it, and VET, that is viscoelastic testing, is difficult to get everywhere possibility. So this is the take or rotem, but I think it is difficult everywhere, but if available, you can think of considering this. However, only VET in this SLA group patients is needed to avoid the overload, unnecessary transfusion, so that you can have a right dose, right time, and the right sequence of therapy you can consider. So if person comes to you SLF, the most important thing is you have to identify the intervention what you want to go. So stratification, whether it is a high risk procedure or an intermediate or low risk procedure. Most of things what we do is paragocentesis, thoracocentesis, or endoscopy with EVL. So this can be considered low risk procedures, and hence this can be considered. And only factor what happens found to predictor for the complications are these two: presence of a sepsis or active sepsis or a AKI. So any SLA patient with sepsis and AKI, try to be more precautious when you are doing EVL or tapping for any therapeutic purposes. And the bleed occurs in the scenarios. First is the sepsis or DIC, which because SLF is a well balanced DIC. If you are going for the emergency procedure, if it is non-mucosal bleed, that is more of coagulopathy related, bleed is balanced, and LAT procedure has a chance of bleed is less. And what are the parameters with us? FFP, everybody know it, platelets, cryo, factor 8, and now come up the PCC. So you should cover this PCC. PCC is now coming up in your fluid to prevent overload. Second, to avoid the loss for the blood transfusion, and you can give very dose. Only thing the cost is prohibitive. However, PCC is a good in patients of critical ill or SLA patients in ICU for the coagulation management. So just to summarize, in a patient of coagulopathy, what we see that patients just to get a diagnosis of having high INR, they pumped FFP or cryo, and the patient landed with overload, sepsis or lung training. So we need to stratify your intervention. Transfusion only needed if you need active bleeding, you need vitamin K anticoagulation, or if you have a rotem-based corrections, PCC may be an option. STPC can consider an RTPC package that causes more of alloimmunization. If at all you think of giving products, cryo is better than the FFP. And most important what we should request here is don't correct the INR. Platelet supplementation has no role, it is very short lasting, it's going to cause more immunization. Prophylactic corrections should not be done, it should be referred. FFP as well as Eltropag for this sick patients are not to be considered. Then comes to the, can we go for the non-transplant recovery is possible? So this is the Indian data, you can see. Most of the centers has shown that you can have a recovery with transplant close to 40%. Nearly half of the patients can be recovered. Here you need to know the definition of SLF. Because the apostle SLF is a pristine group, fast time, nearly half of non-cirrhotics. So this holds good. If you think of any patients coming up as per the Western claim definition, this will be changing. Then if person recover from the acute episode, what is the long time management? You can see if ALF recovers, it is a complete recovery. But if SLF recovers, they will have a residual, we called as a recompensation, regression, or living a stable chronic liver disease patients. So then you have to have a dilemma. So this is, I think, algorithm everyone is well versed with. I just want to highlight that you should need to know the etiology if you have a specific therapy to be considered. You need to know the R-score to stratify them, and few groups like R-score more than 11 or MELD more than 30, please consider start transplant from the beginning. If no, then all the topic I have assigned here, and this is the thing up to consider. with the therapies. If you're going for therapies, we should know how and how long. So this is, you can see, a person comes with the alcoholic SLF, give steroid, wait for 7 days. If reactivation, it is 2 weeks, can tell the output how it will. If you are giving autoimmune hepatitis flare, just think of 7 days of steroids to know whether he is going to make it or no. Delia Wilson's, it is MELD and R score, and others to some extent, but it's not clear. So the purpose of this, that when you diagnose SLF, you can therapy. The most cases you can see, it is the first week that makes the decision for this. Just I want to highlight now the etiology specific therapies. If B, we need to give therapy, yes. Second, which drug to be given, and it is the tenofovir has been studied, and now come up that nearly all drugs are equivalent. Then next comes the whether we should consider any combinations. Now it is a big fancy, even in, I have seen also from the ILBS and Mothership to give dual antivirals. They are dual antivirals, but the most of studies, including ILBS studies, shows there no benefit of giving dual antivirals for this. If giving antibiotics is going to cover. Some studies have compared with nukes with therapeutic plasmexins to be effective. Then next important is the autoimmune, which comes up. Autoimmune hepatitis, most important is your MELD score, and if MELD score is more than 28, that is 29 above, they are likely to be poor responder. If less than 24, they are going to have better response. That is one. And most important for a autoimmune hepatitis for you is when diagnosis is uncertain, to go for a biopsy, because autoimmune in a young female hypothyroid having miscarriage or any sign of skin, you can think of a doubt, but you get nearly 50% of the serology negative. So that's why it is a big dilemma for the SLF to be diagnosed, because these are the group of patients where you can find treatments to get a response to the therapy can be considered, and biopsy is also very difficult to report. And alcoholic hepatitis, everybody know, we have the Indian patients are difficult. We have having mostly the high MELD, and the steroid can give in only hardly 10% of the patients. So that's why SCLF with ascites has a poor outcome. With organ failure, with hepatic encephalopathy, steroid is difficult with AKI and varicose bleed also. So this is only to a limited group with only severe alcoholic hepatitis, or you can give a trial, just see the response how they are responding. Then I think quickly, plasma exchange is now come up. I think it should be taken with a pinch of salt, because plasma exchange only valid for SLF is with Wilson's disease or with ALF, and all for the SLF it is not recommended with any guidelines, it's just a bridging therapy. But most important thing that if you are sitting in a position like Ranchi, then you have to deal the patient's hope and assurance. Patient thinks that, relatives think that there's some treatment when he's going to recover, and the plasma exchange may or may not going to. So you have to first counsel, then think of, because till the studies no survival advantage is found, has to add the adverse effects, add more cost to a critical age, and hence you have to balance the double-edged sword. And to me, I should consider all the things before considering plasma exchange, like additional cost, what should be adverse effects. If I have a donor there, why I want to waste time, and it is bridging but not definitive at any point. Just last to consider is that FMD, I think I'm not going to cover properly, but FMD is going on, but still it is a domain of the research. Now one trial just published that FMD steroid are comparable, but still needs to practically consider. Regenerative therapy is going on, and then everyone is going for the GCSF therapy, it is easier one. Now comes the MSC stem cell based therapy, which is showing little bit of hope, and few studies has come up. So this is the scores. I just want to go most things, but last one is that this is the most important one thing. More sick patients, poor is the outcome. So first counsel the patient of SLF from the beginning. If sick, the transplant option is not there, then you go for. Otherwise, when you refer, then this patient lands with these conditions, so with all drugs, inotropes, where the transplant is not feasible, and you being referred from you for the transplant. So just to summarize my talk, if R score is more than 10, he having any complications of HE, SVP, sepsis, and not responding in a period of 7 days, and first week is definite to take a decision on the call. Supportive therapy to be calculated just to buy time, not as definitive, and then transplant should be considered and needs to be prioritized at the research course setting, particularly for the referral purpose. Thank you.
Thank you, sir. Thank you, Professor Ashok Chaudhary. Now it is open for discussion to the House.
Which steroid is best? Which steroid should be given?
steroids is prednisolone 40 mg standard irrespective of the weight.
Doctor, so KCLF made too simple. Two queries. ACLF subgroup of patients who have infection are a common source of their decompensation. My question is how to monitor those sepsis and their response to treatment. Suppose for SPP, do you recommend retapping at 48 hours to document resolution, number one? And number two, in garden variety of CLD and all, we used terliprosine. Continuous infusion has been shown marginally better, particularly in ACLF. Does this advantage is more?
Yeah. So first of all, any infection monitoring, likely you have highlighted the SBP. I think SBP should be definitely produce tapping should be must, because after 40 years it is no response, call as difficult to treat SBP. If a difficult to treat SBP, mortality is going to be 80% irrespective of therapy. So that's why it has to be done. Second, the point about the terliprosine in ACLF. Now I think we have taken a study on continuous infusion. Otherwise, most of it is a bolus infusion for the even AKI also. So now extrabolus is there.